Hoffwn gyflwyno aelodau annibynnol o'r bwrdd. I would like to introduce the independent members of the board. A'r prif weithredwr ac aelodau gweithredol ac anweithredol o'r bwrdd. And the board chief executive, executive and non-executive board members. Hoffwn gyflwyno nawr gadeirydd y bwrdd, yr athro Donna Mead OBE. I would now like to introduce the chair, Professor Donna Mead OBE.
Bore da pawb, a croeso cynnes iawn I chi gyd am y cyfarfod yma heddiw. Good morning everybody, warm welcome to everyone and welcome to this public board meeting of the Velindre University NHS Trust for November 2023. We have some visitors with us this morning who are going to be with us for the first item. So a very warm welcome to Neil Frau, the Director of Shared Services, and to Tracy Myhill, the Chair of Shared Services. Can I just check, does everybody know Tracy and Neil? They have haven't met. Peter, do you want to introduce yourself?
Hi there, I'm Peter Richardson. I'm the Head of Quality Assurance Regulatory Compliance at the Welsh Blood Service. I'm here as Alan Prosser's deputy.
Thank you.
Thank you.
Anybody on the screen not met Tracy and Neil previously? Or Vicky, do you want to introduce yourself, Vicky?
No, she's just saying hello.
Oh, you're just waving. Oh, sorry, I missed that completely.
Yeah, she's saying hello now. Hi, Vicky.
I missed that, and Alan's now waving. Right, we're not 2 minutes in and I'm confused already, so well done everyone for that. So we're going to have, I'll do apologies and the usual business shortly. First of all, I'm going to welcome Tracy and Neil, and we're going to have a short presentation. We want to get back into the rhythm, Tracy, of having an annual a meeting once a year with yourself and Neil, and perhaps, as was just suggested a few minutes ago, that you attend a board development session kind of at some point in between the two annual meetings. We did have a very successful board development session not so very long ago. As colleagues all know, one of the reasons why, the two reasons why it's important that we have colleagues from Shared Services here. One, we are the hosting body, and two, a number of initiatives which Shared Service are responsible for leading, directing, shaping, affect us directly. So that's two very good reasons why we do need to have a dialogue with our colleagues from Shared Services. So, so that said, we have a slide presentation which has already been circulated.
And it's going to go on screen.
And it's going to go on the screen, is it? So we'll all have access to the slide presentation. And so we're going to ask Neil and Tracy, and I'll leave it to you to how you want to present this, and then we'll have an opportunity for some discussion afterwards. Well, the other thing I was going to say, and I forgot, there are a number of items on our agenda today which are about shared services. You know, there's an approval of the lease, we've got your partnership board minutes to look at and so on. So that's another reason why it's very important that we work as closely as we can and should with shared services. So apologies for forgetting that on my list. Over to Neil and to Tracy.
Thank you. Diolch fawr, Donna. Bore da pawb, good morning everyone. Thanks again for inviting us to come and talk to you from Shared Services. I was doing a little bit of a check-in earlier just to see if you'd had any changes in board membership since we were here last time. Just in case, because there's nothing worse than thinking, who are these Shared Services people? But it seems like it's pretty stable, so that's helpful. So what I won't do is go into what we are and where we came from and the history and the governance and how we relate to you, because I guess you will have heard us say that before and you'll know it anyway. So a big thanks for inviting us here. I agree with you, Donna. I think it would be great. Laura and I have just had a conversation about this as well. If we could come to your public board is good, because I think it's great for the public and the public record in terms of what we're doing and where we are and what we're trying to do. But in between that, have an informal opportunity to get into some more of the detail, particularly around both our roles really, but also in terms of the data we hold on Velindre and other health boards and other health bodies. We want to have the same sort of conversation with you. That's not for today, but I think we thought maybe spring and winter we'll try and
sounds good.
We'll try and get a plan going forward. So the main purpose of today is just to give you an overview really of our integrated medium-term plan 2023 to 2026. I'm pleased to say it's supported by Welsh Government and the Shared Services Partnership Committee, which you know I chair, and that's the committee really that governs a lot of our planning and our decisions. And you're a member there as well, and it's been great to see you there. And Steve joined us as well at our development day with the committee members just a week or so ago. So a big thanks for your support, Steve, in relation to that. And also thanks to Donna, who's taken on the chair representative role at the Welsh Risk Pool Committee, which is another committee I have the pleasure of, and I mean pleasure, of chairing. It's a very, very interesting committee, isn't it, Donna? It's fascinating, and there's a lot of good work goes on there and a lot more to do. But Donna is a very active, I'm sure you will understand, very active contributor to the Welsh Risk Pool, for which I am grateful genuinely for you stepping into that seat. So 2 years since I've been the chair of the Shared Services Partnership Committee, I still feel a bit of a newbie. It takes time, doesn't it? And but it's been great, and your support has been good in that. And we're working, as you know, with everyone across the country in terms of Wales, NHS Wales, to play our part, whether it's in professional advice, provision of good services, leadership at a national level, to try to support wherever we can, particularly given all the challenges that we know we're all facing. I mean, it's not easy, and it's not getting any easier, as the Minister reminds us regularly. So we want to do whatever we can in this shared services space to make life as good as it can be for you as a customer of ours, and also to make your life as easy as possible as our host. Those are our two aims in terms of our relationship with you. So I'm going to hand over to Neil, as you said, the Managing Director, who's going to give you some highlights. We recognise you've got a very long day and a very full agenda, but we'll give you some highlights where we're at, what we're trying to do, and where we want to go into the future. And then we're open for questions, Donna, if you've got the time when we get to that. Is that okay?
Yeah, okay.
Okay, Neil.
Yeah, Tracy, what most organisations say that the most important assets are the people in the organisation, and I had the pleasure last week of attending a presentation for Aidan Davis, who's been working in the NHS for 50 years within supply chain. It was a real privilege to go along to the stores and to listen to some of the stories that Aidan told us over the 50 years. And one of the things I definitely reflected on was how Aidan was able to bring the patient into the majority of his story. And although shared services provides administrative, professional, technical support services to the NHS, at the end of the day, everything that we do does relate back to the patients. And it was interesting how he himself spent some time in hospital, and he was able to see the stores and the stocks and the bits of equipment that he'd actually packed and picked at the stores that ended up on the wards. So just to bring it to life, from a shared services perspective, we are really playing an important role in supporting the patient at the end of the day and health boards. So if you can move on to the next slide, please. Right. Everybody's had the presentation beforehand, so I'll just pick up a few points. So one of the first things that Tracy did when she took over chairing the partnership committee was to really step back and ask the question, are our values, is our mission, our strategic objectives correct? Do we need to relook at them? And we spent quite a bit of time as a partnership committee in a couple of development sessions, looking at our risk appetite, looking at our main strategies, which we've reduced to 3, our people, our services, and our values. We generally felt that the overarching values of the organisation, still listening and learning, taking responsibility, working together, innovation and held true. So we maintained those, but together, I think it was fair to say that the Partnership Committee had the opportunity to look at where we're going in the future and what we need to do with different lens, because previously Margaret had been there for 9 years, and there was the opportunity to refresh the organisation in terms of the strategy map, which you see there in front of you. Do you want to move on to the next slide? Right, so in terms of 23-24, Stacey mentioned our IMTP was approved by the Partnership Committee. It also received approval from Welsh Government more recently in October. There are a number of key deliverables as an organisation that we need to work through, and we have been working through. So none of them should be a, a surprise. Decarbonisation, climate change, definitely trying to implement the digital strategy is a key enabler in everything that we're trying to do, especially around standardisation and efficiencies. Financial sustainability and good governance, that's key, and as host, that's something that we regularly look at, especially in terms of the Audit Committee and the Quality and Safety Committee, which we link into Velindre on. And employee wellbeing. We've spent a lot of time and effort looking at our offering around employee wellbeing, agile working, and our ability to support our staff across Wales. Interestingly, what COVID has shown us is that there are different ways of doing things, and traditionally we would have been very centred around some regional hubs, which we've got, and we're now employing people from far away across Wales into different roles using technology, and that's been a breath of fresh air for us. It's forced us to look at things differently, and we've been able to generate a number of efficiencies and also improve the services that we deliver as a result. Some further examples, some of the solicitors we've been able to appoint, who actually live in Manchester, really high quality and calibre individuals. They would never have potentially moved into Wales previously. So that's given us a different reflection as well as part of that. So in terms of our main key deliverables, there's some examples there on the slide in terms of some of the things that we're trying to do. More recently, we've inherited the laundry services from across Wales. We had a significant programme looking at the rationalisation of those laundries. Unfortunately, due to the constraints around capital, we weren't able to take forward some of the projects that we'd been working on. So essentially, we have been able to secure a limited amount of capital, which has enabled us to do relevant pieces of work around some of the main risk areas. And we are intending to close one of the laundries, which we're currently working on with our. We've been able to get some efficiencies already through a different approach. It is an all Wales laundry. Previously, you'd have 5 different laundries working across Wales. It is an all Wales laundry now working across the country, and we've been able to make a real difference to the staff as well as the service that we provide. So for us, it is about partnership, and all the key deliverables that we've identified as part of our IMTP for 23-26 have been developed in partnership with organisations across Wales, and that's trusts, health boards and the special health authorities. Next slide. This again just gives you a flavour of years 2 and 3. Again, I don't tend to go through in any detail. We've got it there for reference. We've actually started the process of looking at developing next year's IMTP. So we did have a development session more recently with the Partnership Committee, looking at various options and areas that we need to look at going forward. As you'd appreciate, this is about building blocks, and I'm pleased to say that there hasn't been a significant change in some of the areas that the partners wish us to continue to work on over the next period, which would be 24 to 27. Next slide, please. Next slide. Right, so in terms of where we're at, Currently, we have a balanced financial plan. As an organisation, we've been working really hard to make sure that we do have a balanced plan. It is a challenge, as I'm sure every organisation in NHS Wales. There are some significant challenges around the financial risks. They do need careful management. Capital is a pressure for us, and there's a lot of schemes that we have been working on where there is a limited availability of capital. Take some of those areas forward. And again, all organisations have been asked to look to see where they can contribute towards the overall NHS position. We're no different. We've been asked, as well as yourselves and special health authorities, to help contribute towards that. So we have ourselves submitted some options to Welsh Government. 3 areas, one which is around savings that we can produce ourselves, and we've actually increased our dividend that we will pay back to health boards, trusts and special health authorities. The other area is savings that we can help support health boards to deliver. So areas such as medicines, etc., procurement, non-pay expenditure, the things that we've been working with health boards on. And then there are other areas where we do receive some funding from Welsh Government, where we've been working on it, on means to reduce the availability or the requirement for some of that funding. So in particular areas such as the COVID support and some of the distribution that we've been working on around flu and COVID vaccines, we've been looking at different ways of doing that to potentially save some further money for the Welsh Government side. Generally, majority of our planned objectives in our NTP, we are on track to deliver. There are a few that will be carried over into 24-25. And we go through a regular process, and I think it was about 2 weeks ago we had the exec meeting with colleagues in Velindre to go through your performance in more depth and KPIs. That's something that we've reinstigated. We did stop doing those meetings during COVID, recognised some of the challenges and pressures, but it's really important that we put those back into the diary, and that will form a regular part of the process going forward, where we meet every exec team across Wales and go through the performance, KPIs, etc. And as an organisation, we continue to get several additional asks from the Welsh Government and other NHS organisations, which are on top of our plans that we've got in place. So again, it's just some examples of that: international recruitment, vaccines I mentioned, doing more to support organisations, putting in some project management support in, helping Swansea Bay around some of the radio pharmacy and trying to increase their output. Some of the expertise that we've got internally as part of our trans programme. So for us, it is about continuing to support organisations, readiness for the COVID inquiry. That's something that the legal teams have been working on with all organisations across Wales. And again, there might be additional work for us as a shared service as the modules start to come through. International recruitment, the team recently helped support a visit to Kerala. That was very, very positive. A number of doctors that came out of that, which I think is very helpful to the process.
Lots of nurses.
And lots of nurses. So that is, again, that is the second visit. Really good to be done. And again, we can only do that in partnership. So we do need the support of organisations to come with us on those visits and do the interviews and support the staff when they come over to this country. Again, that is one of the challenges around the support package that needs to be put in place for nurses and doctors. But it was a very good visit, and we've sent out more detailed update to organisations on the position for that. But again, we're planning on looking at the next phases for that, because it was very fruitful. We recognise there might be some further disruption in January time in terms of industrial action, and as you know, as part of some of the lead employer bit, we do through Velindre employ all the junior doctors or doctors in training, so we will have a part to play with that, linking in with organisations where they have their placements, plus HAW as well. So that's just, I suppose, a bit of a flavour, presentation to some of the standards across our services. Again, that links in nicely with the recent implementation of the duty of quality, which we are working on with the same as other organisations across Wales. And essentially, we continue to push to try and do the basics really well. So there's lots of new things that we're doing. There's lots of developments. For me, we also need to make sure that we continue to do the basics, the core services, the transactional activities really well, and we look to improve on those. As I said earlier on, digital is a key enabler for that. And I've got a slide a bit later on, just highlight some of the work and projects that we are working on. So next slide, please. Yeah, this is really pleasing. I can confirm that we have actually received the corporate standard for shared services for the Cabinet Office, Customer Service and Excellence. We went through the process recently. A number of my divisions had already got standard, but we were keen on getting an overall standard for shared services. And that means every part of the organisation has been reviewed. It was a long session that we had over a week. 3 different assessors going through all the different services, linking into customers, and I'm pleased to say that they've actually confirmed that we met the standard and have fulfilled the standard. Next slide, please. In terms of our digital priorities, trams, there's a lot of work going on in the tram space. So that's transforming access to medicines. It's one of the main programs that we're working on currently with organisations. This is just a digital element to support that process. It's to be confirmed because there are lots of challenges around securing capital and the site for some of those across Wales and the 3 sites that we're working on. ESR, that is the key system that we use across Wales. For us, it is a payment system for payroll, links into pensions, and it's also the employee single record. So it's the HR element system that the whole of the NHS in Wales use. It is coming up for renewal, and we are working with NHS Business Services Authority on the re-procurement of ESR, which should happen sometime in 2025, I think around August. That does bring a number of challenges for all organisations. It gives us opportunities. So what we've got to make sure, when we've probably about 6 years ago, we had a big push on manager self-service and employee self-service. We had quite a major programme working with organisations trying to get people up to speed in using the technology, streamlining the process, taking the paper out of the system, reducing paper pay slips, reducing forms that lots of organisations have been used to fill in, to make it electronic. In the new world going forward, that will increase even further, and the requirements for people to be able to access and use the systems electronically, and we'll be at the forefront of trying to improve efficiencies and trying to bring the system so it's user friendly, and it's something that every organisation will need to work with us on going forward. Oracle Cloud, that's the main financial system. We are actually, it's a big piece of work that the finance teams across Wales have been doing with us and our central team, looking at the future and again moving to cloud, or moving to the cloud. Traditionally, we've been linked very much into a single data centre through one of the local health boards. That's now going to switch into the cloud. And then again, it's about what do we do as a finance community going forward, which we need to work with. Campus Safety, very important programme that we are working with organisations on, links into some of the legislation that's come in. It is about automation. There are some other benefits around efficiencies and stocks as well, drop out of that, as well as the important benefits of being able to track medical devices and implants, things that have actually gone into patients. Electronic prescription service, You probably noticed in the news recently around a pilot that was done in North Wales, which was bringing the electronic prescription element from the GP to the pharmacy. Currently, we process about 33 million scripts, 80 million-ish items a year through bits of paper. So we've got a team that do that and then make the payments to community pharmacists. That should, or a huge chunk of that should go. It should be streamlined as part of the rollout of the electronic prescription service. For us, it does bring some risks because we have, over the last 10 years, had a programme where the back office bit has been made more electronic and the scripts have been scanned in rather than manually processed. And there has been an electronic element to the dispensing side coming through to us, which has enabled us to process the payments. So we'll still be processing the payments, but hopefully the bits of paper will stop as part of that process. Patient registration, this again is a key system for NHS Wales. So it is the National Health Application and Infrastructure System. Everybody knows it as NHS or Exeter system. It's been around for decades. That is being replaced. So it's 3 sections in terms of the system. One is around payments, which we've worked with colleagues in Northern Ireland. So we've got a strategic relationship with the BSO in Northern Ireland. And we've worked with them around developing the payments side of that system. That is up and running, working really well. Then there's the record flow. So again, it's about moving records around Wales for patients. And then there's the element of registration. So every person in Wales is registered with a GP practice, and this is a system that's used as part of that process. So we're working with the NHS in England around the registration side. There are some challenges. There are a number of patients on both sides of the border, and it's really important that they don't get missed as part of that process. The outputs for some of the NHS system also link into the screening systems. So there will be a new screening system which Public Health Wales run, not us in shared services. So and then the last one is just the workforce intelligence system, which links into primary care arena, provide information which areas of HIW can use, as well as partners around the workforce plan. Next slide. Next slide. Conscious of time, but essentially there are a number of challenges in the environment that we're working through. We are working with Welsh Government on the Value and Sustainability Group, heavily involved in workforce, medicines, prescribing, non-pay and procurement groups, linked into the clinical side and service configuration, supporting some of the work of the NCU around the CAC. It's a challenge, but for us it's about focusing on financial sustainability, helping support organisations where we can. We've got our own challenges around workforce. Some of the planning assumptions that we need to work on going forward. And we've had quite a bit of work done around our accommodation review. So we are looking at, we currently share our building, or they have been West Wales with ABM, well, hopefully again, Swansea Bay might be coming in, but we share it with WAS, Public Health Wales, and we're looking at opportunities where we can to work with others. From an organisational point of view, we're also looking at moving or relocating from our Cardiff hub in Company's House. We've got to move out to the building, and we're looking at moving to another building, but also building in our HQ as well as part of that. So there are some significant savings that will drop out of that process, and we're looking to get that over the line over the next few months. If you want to move on to the next slide. This is just some of the emerging themes and key areas for us that we work with organisations on. This again links to, I suppose, the second element of themes, which will reside in health board trusts and special health bodies books rather than shared services. So it's not getting people in employment safely quicker. It's about some of the challenges around opportunities for medicines. We've set up a medicines value unit as well, and that is already proving to be very positive and delivering some significant savings and identifying a pipeline of opportunities as well to work with organisations. Just conscious of time. So people have read that. So if there's any, I think that's it.
That's incredible amount of detail, a lot to take in there, Neil. You're nearly as busy as we are. So thank you very much for that. I'm going to open it to the floor for any discussions, observations. Gareth, please.
Thank you, Chair. Tracy, you said at the start that you were looking after us as a customer and as your hosting organisation. I suppose looking at it through the other end of the lens, can we do to help you really more than what we think we're doing currently?
I mean, from my perspective, I'm sure Neil will have a view from an MD point of view, but from my perspective as the chair, it works well. It genuinely does. The audit committee works really well. That's where I see you most of the time. I think that's been good. The focus, the way we get into the right level of detail on issues, it's been great. So Neil may well have some other things to add, but from a chair of the committee point of view, it's an easier job in a lot of ways, isn't it? For me, I'm happy with the support I get. But is there one or two things that you think would make?
Yeah, I think make
things even easier or better.
I think the recent changes that we've made in terms of linking into the Quality and Safety Committee, I think that's been really helpful, especially as we've, I won't say diversified, but taken on additional services, so things like medical examiners. We've got SMTL. We have the medicines unit in IP5 as well, so we're producing medicines as well. The wholesaling side, which has worked out really well in terms of being able to deliver service. I think that's worked really well, and I think areas such as the duty of quality. So it's about how can we work together and learn, share some best practice as well. That's one of the things that we need to continue to do. I think the other areas that are helpful is the support that we get generally from Velindre is very positive, and it is a challenging time for everybody.
Yeah.
I think there are some other challenges as well in terms of some of the roles that we provide in supporting areas of Welsh Government. So our specialist estates team, there's a bit of a Chinese wall there because they provide support and advice to Welsh Government on business cases and other things. So there does need to be that bit of separation, which there is, and I think that works really well. Some of the challenges you provide in the audit committee, I think, are really helpful as well.
So is there anything that's not helpful? I know that's not the question, but is there anything anything that could be better?
The area where we need to start to look at going forward is we haven't mentioned, or I haven't had the options to mention some of the work we've been doing on trams.
I'm just going to sort of raise that just
as part of the trams programme. We are bringing forward the development of the radio pharmacy unit, which would be in IP5. So again, it's about how do we work better with you to understand some of your requirements going forward as part of that programme. I know your chief pharmacist is involved in some of the groups, but again, there's opportunities around some of that. So
I'm glad you raised that, Neil, because one of the questions I was going to ask was for an update there, because as you might imagine, just being partisan now, just a Velindre issue, we're beginning to put trams onto our risk register, because when I don't know when you'll be ready to be up and running. As you say, there's an awful lot of water to go under the bridge before you're completely ready. But when we move into the new building, if it isn't ready, we need to have a plan B, because we will be accountable for making sure that the drugs and the radiopharmacy is available for our patients. So we need to keep in close contact on that as it develops. You know, because we could put a lot of work into developing a plan B, and we don't need a plan B. On the other hand, if you know, we do have to be absolutely certain that the day we move in, that we've got a trans survey.
I agree. In terms of that, Donna, there's been the programme business case was supported by Welsh Government Minister. There was a lot of work done on developing the OBCs. So this is not just about the south, as in some linking with Velindre, is about an all Wales service.
Okay.
So that's North Wales and West Wales. So the plan is to put in place 3 hubs across Wales, which will also provide some resilience. The work that we've done does identify the significant amount of products that are being outsourced because of the lack of capability and capacity internally. And as we all know, the demand on services are ever increasing. And as new services are and drugs are come about, there is a requirement again for that to come through. So we recognise that. We have had a number of challenges in terms of acquiring a site as part of the searches. We are, as part of the decarbonisation front as well, we are looking at using electricity, and some of the, when you start to bring the hubs and the clean rooms together into a centre, has a significant power requirement, and there are not a lot of sites across Wales with that amount of power. So we have struggled, and we have had a number of sites. We have had a number of conversations with developers and also potentially purchasing sites. We've now come to, I think, a final decision around developing the IP5. So we've got, as you know, a significant warehouse in Newport, where we put the trans unit or the medicines unit currently. We are looking to develop that site. We've reduced the scope slightly, which will allow us to the classical manufacturing element, which was part of the original scope. We're not saying that we're not doing that, but that's not going to be in the first phase. That will allow us to develop the suites. So we've got, and we've recently received confirmation from our government. We've got funding to develop the plan now to the next stage. The original OBC, we had to go back to re-engineer it because it was unaffordable. So there's been a lot of re-engineering done as part of the work over the recent weeks and months. And we are concentrating on delivering the radiopharmacy in the first instance, although the plan is to develop the whole trans unit in South East in IP5. So that work is ongoing. We're out to tender currently, and we will hopefully be in a position to start to get the final business case into Welsh Government to get that radiopharmacy up and running. But there are delays, so in terms of the equipment, again, that's another challenge for us.
So I'll call Vicky. I'll call you in a minute. So if I can just make a request from here is that we stay close.
Yes.
Because you know we are putting this on our risk register as we get ever closer, and you know it might mean that we keep the existing trams unit in the existing cancer centre as a stopgap if things aren't quite ready, but. It would just stay close.
Yeah, that's fine. Let's just agree.
We will lock in the next few months.
Yeah. Okay, that would be very helpful. Vicky's had her hand up for a long time. Andrew, so if I go to Vicky first, is your hand up then, or you just said, yeah, okay. I'll come to you then, Andrew, and then we kind of time is moving on. Vicky, please.
I think I just wanted to make a comment really that I think the involvement with Ruth now in the Quality QSP committee has been fantastic. I think particularly in reference to your presentation, you know, she was mentioning the quality impact assessments on your IMTP, which I found particularly great in terms of how you're progressing the duty of quality. So that was great. But I think our ability, going back to the sort of strengths of working with you, then actually being able to chair QSP and Ruth attending that, and then actually sitting on the audit committee gives a really good triangulation, which I think is helpful for both organisations. So I thank you for that progress.
Thanks, Vicky. Can I just very quickly say, because when we were here last, in the blood service, I think we had that conversation, didn't we, about quality and safety and where we're at and how we need to get to move that forward. So it's great to hear that from you as well, Vicky. It's sort of a year or so on that we're all feeling we're making progress in that space. So that's good. Thanks for that.
That's great.
It's fantastic.
Yeah, and I notice you're having a deputy medical director as well.
Yeah, the amount of work that's been generated by a single employer, the international recruitment, is significant. So as a resilient as well. So one of the challenges we've been really fortunate to be able to secure Ruth Alvarado as our medical director. Ruth does work 3 days a week. She did have other commitments and they've ceased now. But we do need that resilience. So it's an opportunity, I think, for somebody to come in and to support us. And like I said, the amount of work that's been generated is good. And the duty quality as well is another area that we
absolutely. I can see Alan's hand is up, so I'll go to Andrew, then Alan, and then I think we probably need to move on. Then Andrew,
yeah,
please.
I'll be quick. Couple of points. One relates to I come from a pharmacy department at Cardiff University, so I'm obviously interested in drugs and particularly cost of drugs bill for NHS Wales, which I imagine is enormous. And amongst the most expensive are the cancer therapies, the modern targeted cancer therapies that we use within the cancer centre. So with that in mind, in terms of the cost pressures, and we're all being asked, of course, to look for efficiencies, and things we've thought about and put forward is looking to reduce the drugs bill. Is that an active area?
It is, yeah. I mean,
I guess it would be.
We've already started to provide you with some products, and that's given you quite a big saving.
And I'm sure your pipeline will have some others.
Yeah.
Hopefully, so we can have a conversation.
The thing with that though is, in terms of what we're producing, we've got to do it well, and we've got to do it within terms of what we're able to produce safely. So we're not at this point going to try and produce lots of products because we can't.
Yeah.
So it is very controlled, it is very regulated, and there are a pipeline of products that we're working with all organisations on as part of that. We are bringing in technology to try and improve the efficiencies in the production process as well. There's a number of fillers and machines and other things that the guys are using, which is relatively new technology, but that's where we're at this point in time. But yes, there is a pipeline, and yes, we are keen to support the reduction of the drugs bill.
Quickly on the international recruitment, which I actually think you should call international recruitment and retention, because and I'm interested to know how you identify particular geographies as a pool to recruit from, and I imagine you're probably working with Welsh Government on that. Also, that process of when you get someone in, the specialist from another country, not only welcoming, integrating them, but making sure that this is their long-term home. Yeah, so dealing with everything that's involved in that, and in what is increasingly quite a hostile immigration environment, at least at a UK level. So just to comment more than, I'm just interested to know, how you identify particular areas of the world to recruit from when you're talking about international recruitment to fill particular skills gap within Wales.
I think Kerala has been a net exporter of doctors and nurses for a very long time, isn't it?
Yeah.
And we have to have a government-to-government agreement really before we can go anywhere, don't we? So
We do, yeah. I mean, we are linked into a number of agencies as well as part of that process. But the Kerala one is a direct link through Welsh Government. In terms of retention and when the staff come over, the important point of that is how the local organisations put the umbrella and support around them. And for us, our element, you know, we can help support on the transaction and the administration side. But the important part is how do the organisations then work with those individuals, which is why we're very keen that we are supportive. They do come up with us and are part of the process as well.
We must keep an eye on attrition, because attrition from overseas recruitment is historically very high.
Yeah.
And a lot of work and effort and cash goes into each recruitment. And then it becomes not cost effective if there's high attrition.
Some more, yeah.
So to keep an eye on that, right? And Sarah, I know what you're going to. I'm really mindful of time, everybody. We've quizzed Sarah about supporting our new recruits when they come across, and we've had quite a lot of discussion around the board table. I don't know if did you want to go through that again, Sarah?
No, we can pick that up. What I was going to say was we obviously have that responsibility locally.
Yeah.
Especially this time participating for the first time, so we will be bringing details about through our governance processes, Chair.
Yeah. So we're on the case. We're really on the case for that. One of the most important things is coats to keep warm in the winter. That's one of the things that I found. Make sure they got plenty of. If you take them to Porthcawl or something for a day out, make sure they wrapped up warm. Anyway, Alan, then Nick, and then I'll move on.
To come in on this point.
Oh, okay, come on. Alan, I'll go to Nick because she wants to come in on this point, okay? Thank you.
Just to give assurance to board members that there is an ethical recruitment framework in place nationally which we comply with, and in respect to the recent visit to Kerala, it was the Kerala government that contacted Welsh government, so very much on where there are surplus professionals looking employed, and picking up on the retention. Viv went on behalf of Velindre but went on behalf of Velindre as part of the recruitment. The registrants were very much knew where they wanted to go, and she said it was a lot of them were asking for Wales over other parts of the UK, which was really positive. But actually, what part of Wales, because they've already got connections. So again, that would help with retention. And what the recruitment team did was make sure that we fitted in their needs and wishes where they were offered posts.
Thanks, Nick. Thank you, Alan. Please, last word for yourself.
Thanks, Chair. Can you hear me? Okay, I'm just testing my audio. Can you hear me?
Yeah. Yes.
Sorry, it's fading in and out. Yeah, I think just an appreciation from the Blood Service. There's a level of granularity that shared services provide, and I don't know if that's fully appreciated by the board. We're aware of some of their support services, but I just think from my perspective, their support on the Scan for Safety project, the expertise they're providing to our critical store is really welcome and really helpful. The board may not appreciate that shared services are a key business partner for us in providing urgently cross-mass blood from England into North Wales that is needed and is time critical, and that service runs really sweetly and again very professionally. The procurement support, I asked them to go above and beyond. It's about a UK pipeline and UK and European opportunities. So again, I think some appreciation there. They were a key vaccine partner for us in our holding and distribution, as you can appreciate. And I think going forward for me on the wholesaling perspective, the value-based medicines unit will be critical in supporting our wholesaling arrangements for plasma for medicine. So just a vote of thanks and appreciation, I suppose, from the Welsh Blood Services perspective in some of that add-on, which is beyond just the service support that the board might not be visible to. And I think that's worth, that they're always really welcoming, really supportive, and have kicked through some really hard issues over a period of time for us.
Thanks, Alan. Yeah. So I'll just come back to Tracy for a final word.
I think that's a perfect place to end.
I think it is actually. If anybody else puts their hand up, I'm not taking any notice.
But no, thanks again. Very grateful for your time. I appreciate you've got a long day, and but it's good to at least have that opportunity on your agenda. We'll set up, as we said, twice. We meet in lots of places. So when I say we'll set up, one formal and one informal every year, that doesn't mean we only talk twice a year, just in case anybody's thinking, because we are interacting in lots of different ways, aren't we? in one-to-ones and in committees and other working arrangements. So grateful for your support as always. But Donna, I know you need to get on. So from our perspective,
Thank
Thank
you.
you very much.
Thanks
Thank you
both.
very
That's
much.
really valuable. Thank you.
take care now.
Good as a jet.
Right, okay.
Thank you.
Yeah, thank you.
If you want to move up, anybody? So it doesn't look as if we Carl is Johnny, no mates there. So if I can, that session took a little bit longer, but there was a lot of information and detail there, so I need to catch up on a little bit of time. So if we can move to the business agenda, the substantive business agenda. So we're having a hybrid meeting today, as is the custom now. So I've got people in the room and I've got people on the screen. Lauren is looking out to make sure that I don't miss anybody. She's helping me with that. But if in the room you could raise your hand, and I'll try and notice you as quickly as I can. And I'm going to keep an eye on the screen as well. If you could raise your hands electronically, that would be great. Okay, I got apologies. If I go to 2.1.0, Kath O'Brien and David Cogan, our patient representative. Are there any other apologies that I've not been made aware of? Colleagues.
Stephen Harry's.
No, I was just going to say,
Well, Stephen is there,
yeah.
but he's not got his camera on because the signal is low.
All right. Okay.
And
Stephen,
Martin Fields.
Stephen, can you hear me?
I certainly can, Chair. Thank you very much. To say the connection here is quite poor. I'm overseas, so but I am here listening intently.
Thank you, Stephen. And I thought it was real bad form of you to email me earlier in the week and tell me what the temperature was like in Tenerife or wherever you are. I thought that was real bad form. Because I had to dig the frost off the windscreen this morning. Anyway, we have in attendance Alan Prosser, as you all know, Director of Welsh Blood Service, Rachel Hennessy, the Interim Director of Velindre Cancer Service, Peter Richardson, and see Peter. Yeah, I'm going to say I haven't seen you yet, but I've spoken to you twice. Sorry, Peter. Head of Quality Assurance and Regulatory Compliance. Carl is joining us later, I think. Is he? Carl Taylor?
Yeah.
Yeah, okay. And Tina Jenkins will be joining us later. Is that right, Nikki?
No, she unfortunately unable to.
Will you take any? Okay, that's fine. And as usual, Kate February from Audit Wales. Lovely to see you in the flesh, as it were, Kate. That's really great. So, have I missed anybody out, Lauren, that you're aware of?
Alan, you did just have your hand up, but you put it back down.
No, your hand is up, Alan.
Sorry, I'm struggling with Zoom this morning. Yeah, just to let you know that I'm going to have to duck out in about an hour's time or less, which is why Peter's there to pick up some of the papers. But I'll be dialing into the private session because I've got to jump on a train.
Okay, thank you, Alan. Thank you. So if I could take this to 2.30, are there any interest pertinent to the items on today's agenda which haven't already been declared? There's the opportunity to declare them now. Can't see anything on screen, nothing in the room, so there are no additional declarations of interest. Could I take you then, please, to 2.40? Oh, my I think this went off. Just 1 minute. When you're panicking like this is when you come back. So the minutes of the Public Trust Board meeting held on the 28th of the 9th, 2023, looking to get agreement that they're an accurate record of the meeting on the 28th of September. Any correct, or Hillary, not Hillary, Vicky, please.
Sorry, unmute myself might help. Just wanted to raise on page 4, the digital risk deep dive was outlined that was going to occur in the November QSP. That wasn't agended for that meeting. And I think the plan is for January. So just in terms of accuracy of those minutes, that was what was stated at the time, but obviously that hasn't occurred. And just a request really that on page 5, the risk appetite refresh, which talks about removal of the risks that have an impact of 5. That's still open on the action log, and just a request that we discuss that when we come to the risk agenda.
Vicky, can I just take corrections and accuracy first? We'll do matters arising then next after that.
Okay.
So are there any other corrections to the minutes, please?
No.
Oh, sorry, Gareth.
I was just going to say, Chair, I thought they were an excellent set of minutes.
I didn't have many corrections to make. I had some queries, but they were more about me making sure I understood because it's been a long time since September. I just wanted to check under 3.3 on page 3 of 13 at the bottom of the page where it says that we're in minimal intervention. I thought that was we were in routine measures. Or am I splitting hairs?
Yeah, it is
Pardon?
routine measures.
So, would that say routine measures then, please?
Yeah.
So that's all. That's the only correction
Routine arrangements. Yeah.
that I have. Right. So if I can go to the action log. So, Vicky, I'll call you in just a second. The action log is 2.5. Sorry, I should conclude by saying we confirm, apart from one correction, that the minutes are accurate.
Let's clarify on that because in terms of when you say the routine arrangements bit.
Yeah.
Yeah. Sorry.
Yeah. So if we come to the action log, please. I think all actions on the action log are closed. So first of all, I'd like to just check that everybody's content that these actions are indeed closed.
Except for the one that Vicky mentioned around there.
And I was just going to go back to Vicky and say, do you want to raise your particular point, Vicky, at this now?
Yeah, I think just on the action log, the actual one that I'm referencing is actually open. Well, certainly the version that I've reviewed. But it was really just, it would be really helpful when we're coming to the risk paper to actually have that discussion, because it's actually saying that will be included in papers in January. But actually, we just need to know how that's been managed here and now in terms of the risks that have an impact of 5. So just asking if we can include that in the risk paper so that we have some verbal assurance of what's happening right now.
I think we can do that, can't we?
Yeah.
Yeah, I think we can do that. Thanks, Vicky. Anything else, Vicky? I'll give an opportunity for any outstanding matters arising not on the action log in a second. Gareth, please.
Thank you, Chair. It's in relation to the last action, which is 3.2.0, and I've corresponded with Lauren on that. I think the action is inaccurate because it was seek approval of trust assurance framework either via Chair's urgent action or meeting / discussion at board, and I think we've come to the conclusion that the discussion around strategic risks should be done at board rather than via a Chair's urgent action, and it is on today's agenda.
Yeah,
but I'm not sure that the action is closed as such.
Yeah. So
this is 3.2.0. Yes.
Yes. So the reason I closed it is the action was to agree the process by which the trust assurance framework risks were going to be approved. And after discussion at Audit Committee, we agreed that it shouldn't be an urgent Chair's action. And then that was confirmed in an email to the board that it would come here. So it's for, so I can, so it was the process by which, as opposed to the approval. But I can add more detail in because that isn't clear.
No, so I think we need to amend the action in order to
Yeah.
reflect what I just said.
Yes.
And also maybe update the comment just
Yeah,
to,
sure.
On the right-hand side then, yeah.
Yeah.
Would we agree to do that, Lauren, please?
Yes, of course.
we can then close it if it's
Yeah, that's great.
Okay, any other comments in relation to the action log? And if not, are there any matters arising from the minutes of September which are not contained in the action log that colleagues would like to raise now? No? That's good, thank you very much. And so we come to key reports, section 3. First one is my chair's report. And I think when you read through it, you'll see that I have attended a number of events. And the reason I include them in my chair's report is not to say, look, the chair's been very busy, which I have been, of course, but it's because the purpose of attending so many of these is to connect with our staff in various places, with patients, with donors in various places, and that's the reason why I engage in so many meetings across the trust, either because I'm supporting the charity, I'm supporting our staff, or want to make connection with our patients or our donors. So I'll take any questions on the report. I'm not going to go through it in detail. It has been a very busy month. Just maybe add, because it's hot off the press, that I attended a Improvement Cymru's event that Nicola and her team led. That yesterday, Nick? Tuesday. Good Lord. On Tuesday, and we had a number of presentations. This is part of a national initiative that Velindre is participating in with Improvement Cymru, and it was extremely informative event, and I think there are a number of things that we're going to pick up as a consequence. It was really good to see 3 executive directors at that meeting, and we had a medical director from Welsh Blood was present at the meeting. We did have a number of presentations from Welsh Blood. It was I was really assured that there's a concerted effort across the trust on the day-to-dayness of what we do to seek improvement using a methodology which is tried and tested. So it was an excellent event. If other IMs wanted to come, Nick, as we have future events, could they be invited? Would you like to be invited? I wasn't too disruptive, was I? It was I'll take
very appreciative of you being there.
Yeah. I learned so much. Vicky, you'll be pleased to know that it finally sunk into me the difference between I know Nick is she's smiling at me, the difference between targets and quality metrics, and how they're so very different. And I've come to that and open perhaps a bit of a discussion about that in the performance report later. So that's a 30-minute warning for you, Nick. But I'll come to that a bit later on. So then, Stephen, please, if I can't see any hands up, we'll have your Vice Chair's report.
Thank you, Chair. I say it's there. I can take it as read. I'm not proposing to go through it. Obviously, I'll take any questions or comments. The one thing I just wanted to, I've got to do 2 things. One is I've got to check if my raise hand is working, because I did have my hand raised during the action log for a reason I'll explain in a moment. So I just agreed this with Lauren. Is my hand showing as raised now?
Yeah, so it is on my laptop. It just didn't come up on the main screen. So
that's no problem.
It's all right. I'll stay with this for you now.
Okay, I'll just lower that. Sorry, it does actually fit with my report. It was just actually going back to the first item on the action log, where I wrote to Becky Bowie to congratulate her on behalf of the board regarding her qualifying as an assistant practitioner, just to say to the board, I've had a very appreciative response back from Becky. She wanted me to pass her thanks and appreciation on to the board, and also just to highlight that she wouldn't have been able to achieve that qualification without the full support of her manager, Jeanette, and the whole team in the outpatient department. So I'm just passing that appreciation back to the board from Becky, and that's the first item on the action log. And as I say, Chair, I'll take any questions or comments on my report.
I can't see any hands up. Lauren, any electronic hands up?
No.
Thank you. Thanks, Stephen, for that. I just realised that in my chair's report there's a bit of detail missing under the Wrexham Collections team visit. I think Alan Prosser is still there. So the Wrexham Collections team and the Hospital Services Stockholding Unit, known as SHU, both achieved gold awards for between them 13 improvements made between July and September. And that bit of detail isn't included in the report. It just said they received gold awards, and you can't. There's no mention of what the awards were for. So I had that in my notes, and I forgot to mention that. So if I can take us to the Chief Exec's report, please, and hand over to you, Steve, for that.
Thank you, Chair. Just a few things. I won't go into huge amount of detail on these, conscious of time. The joint exec team meeting occurred a few weeks back. We're still waiting for the formal note of the meeting, which we'll get in due course. I've attached the success. It was a slightly different format last time. So we had a 6-month look back and 6-month look forward. Some other things, and they wanted us to include some successes, so I've included those and attached them to a report, because it's not something we always focus on, but I think it's important to actually bring these together, as I think some of them have been mentioned before. I've included the note that David Powell and myself sent out about the new cancer centre on here in terms of the progress as we move forward. The working together staff sessions, probably a bigger topic we need to come back to, is where we're going with building our futures together, and that alignment with things like the values conversation we're having, but also the engagement we're having with staff and the connections we're making as an organisation, which is where these sessions fit in. And the last but not least, actually, the first clinical and scientific board meeting occurred 2 weeks ago, I think, and Nick, you chaired that. There was a lot of energy in the room, I think, was the conversation you and I had. It's a big step for us, I think, organisation, in terms of that balance we want to achieve between the business part of what we do and the clinical and scientific nature of the organisation. And I think we'll keep an eye on that and make sure that people can get the value out of it that we want from the input they're putting in. And clearly we'll be working on the strategy development as part of that work. So I think I'll stop there and just open it up for any questions, Donna.
Thanks. Thank you, Steve. Did you notice that the JET slide deck is in your pack, and I think it was circulated beforehand as well?
It's just the successes, 3 slides.
Yeah. Oh, okay. Yeah. Right. I find the slide deck really, really helpful as a kind of in one place update as to our progress and recent developments. Any questions or queries for Steve? No? Thank you. So we come to 3.4.0, which is the next in our series of board champion reports, and this time it's for infection prevention, vulnerable adults, and violence and aggression champion. And you're going to talk to us about certain aspects of that role, Vicky. Let me just find it in my papers. Got it. Over to you, Vicky.
Okay, thank you. Well, you know, as the previous commentaries have said, I'll take the report as read. I think it's just important from a champion point of view just to give the board the context of how I've undertaken some of those roles, which I've set out in the paper. And really, it's all about triangulation of information. So as chair of QSP, obviously receive infection prevention and control papers and updates. We receive the annual report, and the same with safeguarding. But actually, for me, it's important to take a deep dive and just listen into some of the committees which Nick chairs on both of those issues in terms of infection prevention and control and safeguarding. And I think there you can actually hear and listen and see the papers that actually go into a lot more detail than I would receive at QSP and indeed at the board. So I've set out the two sections in terms of infection prevention and control. I've set out some of the key achievements, but as a board, we've seen the annual reports in July on both of those issues. But I think the governance is really important in terms of how the Infection Control Committee manage their business and the key issues that come from that. And certainly I took a lot of assurance by attending that, but also the papers as they come through. But I think that the additional triangulation is the 15-step challenge, where I've gone on all of the occasions with Nick, and I've set out in the appendix the number of 15-step visits that I've undertaken. But I think that could be undertaken with any of the exec directors. That needn't be Nick, but I think because Nick leads on both of the issues that I've outlined in this report, that's been particularly helpful to me. And I think really just the same with safeguarding as I've set out, because it's the same approach with both of those issues. I think what I guess for us as a board is really important is some of the expertise that sits in the infection prevention team and in the safeguarding team sometimes leads to turnover. Because actually, as we know, Tina has recently gained substantive promotion in her role, which left a vacancy within the safeguarding team. But actually, with Nick and Tina's oversight, then they've been managing that extremely well, but it has led to a bit of a backlog in terms of training. But actually, the committee was very focused on how they now move that forward with some additional roles, particularly in terms of mental capacity training, which is great to see. So I'll stop there. The 15-step challenge, as I said, triangulates all of those processes. That's now with Nick and Jazz, where they would track that through and report through to QSP, so we can keep an eagle eye on all of those issues. So happy to take any questions.
Thanks, Vicky. I think it would be helpful in a future report if all the 15-step challenges could be captured. Maybe you don't need all the detail here because it goes through to, I'll come to you now, Nick, in a minute, because it goes through to QSP, but there have been other 15-step challenges. I did one with Matt Vance, for example. I know Hilary, you've done one, Hilary's done two, so that it's, that we capture the activity across the board, and we'd like to get more IMs involved in 15-step challenges. I certainly got a lot of the one that we did very recently, where Matt and I visited the stem cell collection unit in the cancer centre. So having said that, any what do you want to raise, any issues?
We did one myself and Steve with Kyle yesterday.
Oh yes, you did, didn't you?
Yes, very, very good.
Yeah.
So again, being reported through to QSP.
So the 15-step challenges are happening more ubiquitously than the report would suggest. Thanks, Andrew, for reminding me of that. Nick, please.
Yes, just on that matter. So the report just details those that Vicky and her IM role were involved in, and we have, as colleagues have just mentioned, changed the process around the 15-step visits. We're using the terminology visits now rather than challenge, because it's a far more positive term to be used, and so we do need to bring all those together now and take it to the Quality and Safety Committee in January, because there have been a number of visits now with different executives and independent members, which was always the intention.
Absolutely, and can I just mention that we should acknowledge the work of the administrative staff that accompany us and take down all of the details. So much goes on in one of those visits, and they, well, the ones that I've been involved in, the ones I've read, they capture very precisely what happened during the visit, and just want to acknowledge that they too are part of the process, important part of the process. Yeah, and if there are lessons to be learned, we need to know, are there similar lessons, you know, for different visits? Are there common themes that are coming out? Which is why we need to look into the totality of the 15-step visits, and you know, for all the IMs and all the directors, to see if there are common themes or not coming out. Any other queries for Vicky or observations? Thanks for it's a very detailed report, Vicky. Thank you so much for that. Are we having the Welsh language one next? I think so. Welsh language will be next. If I can take us then, please, to section 4. We're noting the report from Vicky. We're noting just the content of the report and the subsequent discussion, please. And then for section 4, it's the quality, safety and performance section. And we go first to the Trust Risk Register. I'm going to hand over to my colleague on my right, Lauren, to take us through this.
Thank you, Chair. So the paper highlights the development that we've been talking about in the previous governance cycle of the way in which we approach and manage risk and report on it through governance in section 4.3. So we've pulled that together. Previously we were just doing it in narrative, but hopefully that's a useful format for people to track. So the summary from Audit Committee, Trust Board and Quality, Safety and Performance Committee from the last cycle. And in section 4.2, the summary of each of the risks reported is pulled out in the cover paper. Again, hopefully that's a way of being able to focus from a scrutiny and assurance perspective on what's changed on those risks during the last period. And again, that's in the appendix in a clearer way. The third thing I was going to say was on it's summarised in the previous governance section, but just to highlight the discussion we had at Audit Committee on the level of assurance on this paper at the moment is a level 2. And there was discussion around whether that was appropriate, because the definition of outcomes of level 2 is that the actions being taken are having a meaningful impact. And due to the static scoring of some of the risks that is still at the highest score, it was, Vicky raised the question first around, was it therefore appropriate to stay at a 2? So what we agreed at Audit Committee was that we would keep that under review and come back to it at the next committee in December based on this this further governance cycle of reporting. So just to pick up on your impact level 5, Vicky. So the I mean, we obviously used to report on level 5 impacts at board and stop that, as we talked about last time, when we refreshed the risk appetite about a year ago. So we are going to reinstate the reporting as we previously had it. In the meantime, there's 2 in the table in 4.3. There are 2 additional actions which Peter and I, in our trust risk group, where colleagues who are involved in managing risk and facilitating that across the organisation. So we meet up on a regular basis to work all of this through. So there were 2 additional aspects which came out of the meeting yesterday, which will be taken to Executive Management Board next week, one of which directly relates to this point, Vicky. So as well as reporting the impact level 5s, the suggestion from you, Peter, give you the credit, was what we could also do is report when there are risks that are initially loaded onto the system that have an inherent score which is above the risk appetite. So no matter what the view of the effectiveness of that control framework is from a management perspective, the inherent score are reported once with the articulation of those controls, obviously from Datex, and that will give then another further assurance of it's approaching that question in a second way. So we'll start doing both of those things, and the rest of the activity is laid out in 4.3, as I said.
Thanks, Lauren. Vicky, do you want to come back on that in relation to impact score higher than 5?
Yeah, so that's great. So thank you for that, Lauren. So will that be reported through both QSP and Audit Committee as well as the board in terms of those that come through initially?
Yeah.
Yeah. Thank you.
Yep. So, Gareth, please.
Thank you, Chair. I'm just going to pick up on Lauren's point about the assurance level at Audit Committee, and you represented the discussion faithfully. Thank you for that. I just wanted to check whether this part of the risk report is the one that will come to the December Audit Committee, or whether there is going to be a refreshed one, because the reason for asking is that really with all of, well, the majority of these risks, I think, if not all of them, we're still on a static score, and there hasn't been any reduction, which is not what we would want to see. And clearly, without prejudging this, but in the December Audit Committee meeting, I think we will be looking seriously at reducing the assurance level to 1, which is clearly not where we want to be either. So the clarification as to whether this will be refreshed before December and or some Audit Committee meeting, and whether we can hope to see some reduction in the risks.
Yeah, so it will be. So the November data is going to EMB run on Monday.
Right.
So that will then come through to the Audit Committee on the 18th.
Right.
And so in terms of the reduction in the scores, it's the other point just to make on that is it's not only the risks that are reported. What we will also show is from this cycle and the November cycle of the risks that have reduced in score, because we're not currently reporting that. So they.
So that explains why they're static or they don't seem to move.
We see the ones that
you only see the ones that have got a high score, not the ones that have a high
I'm
score.
Thinking of I'm the next paper, which Lauren, I'm looking at these scores where you do the month by month score, and most of them don't change month to month, and that doesn't correspond with the narrative actually, because the narrative suggests things have moved and changed.
Yes, so I was sorry, making a different point, which was the in what we don't do at the moment is where there's a score that's then reduced below the risk appetite level of reporting at board. We don't capture that in the report. Right. So we are for the EMB paper on Monday, that'll then come through to Audit Committee. So there should be evidence in 2 ways: the reduction of the scores that are here, and there's been significant discussion at EMB, as we talked about in this document here, on some of those scores, which has been worked through by the teams during this cycle. Plus, then the cover paper will show those scores that have then reduced below this level.
Okay. We'll await the paper. Reserve judgment till then.
Reserve judgment. Oh, that's a good term from legal exit. Steve. Is that your hand up as well? Right, I'll come to you in a second. Okay, please.
So I was just going to say, at the moment, the report looks risk management in the trust through a very narrow lens. And I think that the point Lauren was making, and we told it, was how to show the wider lens of how we are managing risks, whilst still looking at the ones that are constantly at the level as well. So it gives you a broader picture, because otherwise you think, well, we're not managing any risks because these ones are staying at that level.
If I may come back on that, Chad, it's a slightly different point, isn't it? In that you're looking at other risks, not just these, and saying, well, these are other risks that are reducing. But at the moment, the Trust Board and Audit Committee only have visibility of these risks, and they're static. And it's the concern that we need to see some reduction in these as well.
And both those points are important. Like you actually get broad understanding of how we handle risk in the organisation.
Just say something in relation to that. I don't know. Because one of the other bit that was a suggestion from Audit Committee, which we will do on Monday, is which number is it? Yeah, so 7A is E&B. So for the version of the paper that will go to the 18th committee, will explicitly have an assurance that we are comfortable with the score or not.
Yeah.
Because there are instances here where, because the target risk score is a couple of years' time, and so if it so happens that E&B is comfortable with the static score because of this rationale, again, that'll just be written in a far more explicit way from the next version.
And yeah, we will need to understand the rationale behind that.
Yeah, and they'll save us having to try to unpick it each time.
Yeah, exactly.
Because it'll be explained then.
Yeah.
Yeah, that's helpful. Hilary, please.
I was just going to ask, because the actions columns in the risk register itself isn't clear either on what is happening. Some of them are out of date, some of them are, doesn't say who's necessarily responsible for them. There's one, just look at the Brachy workforce one, for example. It says that the risk is overdue, a smart action plan needs to be developed, but the smart action plan needs to be developed by 28th of March 23. So
if Rachel wants to pick up.
So have you got a specific one there, Hilary?
Yeah, there's
yeah,
2515.
2515. What did I want to raise? Oh, I've got 2515 down. I've got that exact point written down in my notes as well.
Great minds think alike.
See there, look, 2515. There it is.
Yeah, no, I can vouch for that, Chair.
So this is one of Rachel's risks. She's got her hand up.
We've got an individual who's due to return to work in May 23. We don't know if this happened or whether that's a typo and it should be a different date. Someone's due to start maternity leave in July 23. This is clearly a risk which isn't up to date in terms of its actions. Yeah.
Well, the action columns in general, I think, should be more explicit. They should be smart. They're not smart.
Yeah, Rachel, did you want to respond to those particular points, please?
All right, sorry, just saw to my microphone. I think for us, coming back to the general position in terms of why some of the, in particular, the workforce related risks, we're not seeing a reduction in that risk, is because it's reflective of the national picture and the difficulty in recruiting to some of these very specialist posts. That's not to say there isn't work going on in terms around how we sustain the service, but it is a general challenge, not just for Velindre, but also for the wider NHS. And what we're seeing, I think, in some of these in particular, in the last one, you referenced the brachytherapy one, is that the fragility of the service. So whilst the initial risk may be addressed, then another element of the workforce is changing, which is maintaining that that level of challenge to sustainability. We can go away and update some of this. It should have been updated, so apologies if it hasn't been. But in terms of that maintenance of that that risk level, it is reflective of the challenge with the workforce, which is also reflected in a number of the other papers coming through our governance channels.
Want to come back, Hilary?
Yeah, I think what I would say about that is I do think that we do hear what's being done, but it's not reflected in the register itself, which is
that is a fair point, Rachel. That, you know,
but this is public facing. Sorry.
Yes, I'm agreeing with you entirely, Hilary. Don't want to make extra work for you. I know you're all, you know, you're it's a huge amount of work for you to cover. But it kind of leaves us a bit high and dry because what you just said to us is not visible in this risk register. if you could have a think about that, Rachel, that would be really helpful, because that would give us the assurance that we need, wouldn't it? If we saw some of that activity being set out in the risk register. I want to ask, oh, go on.
Sorry, just to say, Sarah did point out this morning that there was another example on 3001, where for some reason this extracted datex must have had a glitch on that action because it hasn't been closed in the way that it has on datex. So we can just double check, Rachel, if that's the same, if there's anything that's happened in terms of 2515, and if that's the case, just recirculate and republish. So apologies if that has happened, because I'm not quite sure how it would have done, but
somebody would check.
There has been another, but we will, because
that's circled as well.
And then, okay, and then we would retract the comment then, but
of actions under 3001 which are out of date on here, but actually up to date they're closed. So actually they're not, that's not being reflected here as well as said. So because it does look why there's such old actions on there, but actually they are closed on datex, but the extract is pulling them through for some reason, which it shouldn't do. So but recognise also the point around smart actions. Velindre, thank you.
Thank you, Sarah. I have a plea to make, which is to sanity check before these papers are submitted to board. So, for an example, cancer site is spelled S-I-G-H-T, and it's not cancer; it's S-I-T. It's a site, not a line of sight. It's a cancer site, and the tense. I mean, risk language. You know, you have to get used to the language of risk. But there's a sentence here which says the impact is severe harm, which may result in national report of incidents. And I think it's the impact could be severe harm, because I'm starting to look, where's the severe harm? Why hasn't that been reported? And so I think if somebody could sanity check and make sure, or sense check, is that the word? Not sanity check, apologies. Sense check, to make sure that we got the tenses right. I apologise for thinking sanity check. I don't know why I said that. Sense check it so that the tenses are correct. I would be very grateful for that. Gareth, please.
Could I just ask a question on the back of what Sarah just said? Does datex also then update the rating? Because as Sarah was saying, in respect of 3001, that a number of the actions has been closed, but the current risk rating is still 12. So if the actions have been closed, shouldn't that have resulted in a reduction in the 12 score?
Exactly. Yeah. Yeah.
Chair, I think this reflects conversations we've had previously at this committee, that the scoring mechanism is so blunt. Actually, when it comes to something as broad as health and well-being, staff health and well-being, when we review risk, which we do regularly within my team, within the Healthy and Engaged Steering Group, the decision was made that there isn't sufficient change in our KPIs around health and well-being to justify a reduction in the risk score. So you're right that certain actions have been completed, but actually, when we move from a 9 to less than 9, from a 12 rather to a 9, that's a big reduction. And what we feel is that we're not justified in doing that, because this is a long-term systemic risk in terms of health and well-being. So that's why it does look a bit odd when it just flatlines in terms of current score. But when we continue to have the conversation, we can't feel that if we came back here and said it's gone from a 12 to a 9, you'd be rightly saying, can you evidence why you feel there's a reduction from 12 to 9 in staff health and well-being?
So is that fit for purpose then? That being the case, it hasn't got sufficient sensitivity or specificity.
They are not changing from 5 to 5.
To be fit
every
for
other
purpose.
NHS organisation.
That's continuing. When something like health and well-being, it is a continual challenge to then justify why we might change that score.
Lauren wants to come in, then I'll come back to you, Gareth. Lauren, Jazz, sorry, wants to come in.
I just wonder whether we, in that situation, it may help for us to actually put that in a narrative to say, we have looked at this risk
And in spite of the fact that we have closed many of the actions, we feel it still needs to read Act 12 for these reasons.
Yeah.
That then qualifies just to a certain extent why.
I think that would be helpful. Sorry, Sarah. But I'm assuming then, if the reduction, there hasn't been a reduction in the rating, that there is still outstanding actions which haven't been completed.
Yes.
Because if all of the actions have been completed against that particular risk, then clearly they're not the right actions in order to reduce the risk.
Or the target action is wrong. Target rating is wrong.
Yeah.
Or they're beyond our control. Yeah.
So, Camille.
I was just going to make a point here. I mean, sometimes we have very ambitious target ratings for things that we have little control over. We can do all the things we want to do, but we need to be honest about that. And so there's two scenarios to play out. One is environmental things change our risk, so as we do things, the environment changes and impacts. And the other one is, I think we are over ambitious in some of our time. We've had this conversation in the MB, and I've had that with Lauren. We shouldn't chase a low target because we think it's the right thing to do. We should chase one that reflects where we think we can get to. And then it's about us holding the residual risk as an organisation and understanding that's where it is. And I think it takes us to that point. We can have an honest conversation. And if we are clear, I think your point then, Giles, is that the rationale within which we have cleared actions, we are looking for more, and we might have added more, but actually, residually, it's still where we are, because the environment we operate in, it is really tough.
Yeah, and a better narrative would help.
Yes, it would.
The independent members understand.
And when we're down to 4, we should be able to capture that in terms of it.
Yeah, and that'll be the outcome of that action 7A.
Sarah.
Sorry, just to reiterate what Lauren just said, that I think is the purpose of what Lauren was suggesting earlier around describing why we are holding risks at a similar level and not seeing a reduction.
And that explicit
do that
assurance as to whether EMB is comfortable with that or not.
Yes, so that closes that loop a little bit now.
The ultimate point is these are public facing documents, and so the issues that we've raised, they do need to be contained in these documents as public facing documents. So we appreciate the difficulties. It's a work in progress. We understand all of that. But as we are left a little bit high and dry, if I can put it like that, so would the public be without some of the explanation and the narrative to go alongside the figures and so on that are in the table. Matt.
I suppose it's just to sort of say it's a bit like the different levels or lines of defence on the TAF. So one individual action isn't going to take you to this tipping point of the score moving. We just need to understand those layers. And I don't know how you describe it because it's a blunt tool to measure it, but you've got lots of sophisticated actions going on. And you need to keep a tally of them, and there'll be a point where you have sufficient assurance, we do, to give you as a board that we've tipped now, and we can now say, yeah, the impact has now dropped to that next level. That's what we're just trying to describe. It's really difficult to describe that in these tools, I think, but that's my take.
But we have to leave it to the officers to get this right. What we're asking for as independent members is explain as you go along, and because these are public facing documents.
Straight in the story.
Yeah.
Keep reminding what we've done on the previous bit of the story, and then what's the next year.
So in relation to the risk register, we noted the risks at level 15 as well as risks in the safety domain, the risk level of 12 that are highlighted in the paper, and we note the ongoing development of the trust risk framework and invite the officers to take on board the suggestions that IMs have made in relation to how matters are communicated through this paper.
Mm-hmm.
So that concludes 4.10. So now we come to the TAF, which is looking up, no hands up, 4.2. Then, Lauren, this is for you to give us an update in respect to the trust assurance framework.
Yeah, so This paper, going back to the action law discussion, is for discussion, and then the version with the final two TAF risks will be for approval in the January cycle on financial stability and patient outcomes. As we also talked about in Quality, Safety and Performance Committee, they were the two risks which came out at the end of the review cycle. Again, the approach in terms of development is captured now, hopefully in a clearer way, in 3.2. And then just the third thing I was going to say up front was had some good discussions with Vicky around the development of our approach to strategic goals and risks going forwards. And it's something that I'll have a chat to Nicola and Gareth about next week as well, in the context of the governance assurance and risk programme of work and the development of that. And it may be that Vicky wants to input into that as well, because it's an area that from a TAF perspective we would want to continue to develop, but then also without stealing thunder of structure assessment when it lands, because we got the first draft from Kate yesterday, the further feedback and thoughts from Kate around strategic goals and being far more specific on that also will then come into that same discussion. So goals and risks strategically coming together and the time that we spend on it as a board for future development.
Thank you, Lauren. I'm looking to see if anybody's got any queries or observations to make. Oh, Vicky, please, your hand is up.
I think it's just to agree with Lauren's point there. I think it's really important that as a board we spend some development time on the alignment of strategic objectives, because our IMTP has specific strategic objectives for this year, and at the moment we haven't got those included within the TAF. And you'll see in the highlight reports that both the Audit Committee and QSP have highlighted the need for that alignment. And I guess just in terms of timescales, we really need to try and tie all this together so that we've got a completed TAF that then is just being updated, and we can seek assurance as a board that actually the risk mitigations are supporting our delivery of our strategic objectives. So it's repeating some of the points that Lauren has said, but I think it is really important that we do that at pace and can see that completed document, but we have development discussions at a board.
So as you say, Vicky, all of that, apart from development pace, is contained in the paper. And what Vicky is asking us to do is how quickly can we move forward on this, Lauren? I hand over to you for that.
So
sorry to put you on the spot.
No, I know. So in terms of well, I guess it's up to you because it's your board development time. So we can have a think about how we do it, and then when we want to schedule that in.
Yeah. Yes. Okay. That's a very neat pass it back to the chair, because we have sort of set the agenda for our next board development session is in 2 weeks. So and we've got lots of individuals invited to attend, so we may not get to it.
I would dare to assume which agenda you would want to.
Yeah, we'll sort out outside the meeting which agenda we put this on to, Vicky, but point taken. No hands up. So we note the developments in relation to the trust assurance framework. I think it would be helpful. I'm not trying to be defensive in any way here. The points Vicky has made are well made. The points of concern raised in the report are well made. But at some point, we need to look at where we were and how far we've come. And I don't think we do that often enough as well, because these are not easy nuts to crack. Involve people across the organisation, and we have come a long way. That's not in any way to undermine what you've said, Vicky, about moving forward at pace and what the concerns are. But I sometimes think we forget how far we've come. I just wanted to note that, and we probably haven't come as far as quickly as we would like. So I thought I'd say that before, because there were 2 smiling faces around the table. But we have come a long way. I wanted to note that. I want to, before we go into the next two items, which are the highlight reports from audit and the highlight reports from QSP, I'm just, I should have asked this last night, but then I didn't. Under audit, we're asked to note the highlight report, and under QSP, we're asked to discuss and note. So presumably, they should both be the same.
Yeah, they should be to note because it's noting the escalation.
Yeah. So
yeah, apologies.
So if I can go then to 4.3.0, which is the Public Audit Committee highlight report, which is for noting. Did you want to draw our attention to anything in particular, Gareth? Because I think you chaired this.
Thank you, Chair. I did. Just one point of detail on the first page, presented by Gareth Jones, acting chair there.
Yeah.
Committee. That I was standing in for Martin Veal at the time. And then I think we've already discussed the alert items there regarding the trust risk register and the trust assurance framework. So I don't think we need to revisit that, but the points are well made. But otherwise, I'm assuming that colleagues have read that alert report and happy to take any questions if there are any.
We'll republish with that acting chair because that's.
Matt, I've got a point to raise and advise in relation to sharper funds, but I don't know what your point would be, Matt.
Well, the first one, I mean, it opens a bit the conversation we just had about the TAF. Well, obviously, the paper says without a TAF, it was difficult to delivery of strategic objectives, and I raised that in the audit committee. It's not reflected here that actually we've never been without a TAF. Our internal audit colleagues would agree, because essentially, and I said this in the audit committee, it's not like the previous TAF was on a cliff edge and it suddenly stopped being used by exec directors and the organisation in terms of managing the overarching risks. So we were developing a new TAF in the background. Yes, it hasn't been as quick as I totally accept that we all wanted. We don't just stop looking at those risks. We've been continuing to look at the extant TAF as it was. What are the actions and controls and mechanisms? So the way it's worded implies, oh, we had TAFs finished, there was a cut-off date and it's all ended. They have a gap. Internal audit used that extant TAF for our audit plan, because we had to develop our audit plan back 2 months ago. And they have to link, obviously, the audit plans to our TAF, because that's the aim, is to, are you covering the risks identified in your TAF, which they've done. So it implies that whole audit plan is also defunct. It's not. That internal audit plan is linked. We will then uncouple it from that TAF and link it to the new one. But it's a live document until such a time as we sign off the replacement, surely. That just seems nonsensical to think that we
come back on that, Chair, if I may.
Yes, please.
We have the discussion on audit, I accept, but so far as independent members are concerned and the various committees and this board, we have no visibility of an extant TAF for 6 months almost.
Yeah, I think that is a fair point.
So I think
it's different to what this is described as, though there is no TAF.
I think well, we have no evidence that executives were continuing to review the old TAF. And I think it's a fair summation that we weren't cited on any of that.
Well, those.
You probably picked up the one point. There's two others. We refer to actions as blue status. Nobody's going to know what that means, so we just need to say closed in this report. And then the other one is your flagging. It doesn't reflect that the delegated limits related to the CFC. It just implies delegated limits. It's obviously not for the trust revenue position. It's the.
It's just, yes, that's for the Charitable Funds Committee, because it would reduce your delegated limits from 100,000 to 25.
It needs to be explained.
We'd have an awful lot more going out.
We'd have a lot out of committee, so it needs to, we need to note in the minutes that that refers to applications for spend against charitable funds that we've increased the delegated authority from 5,000 to 25,000.
Yeah, which is reflected in the standing orders paper. Yeah,
But it's a fair point.
they're absolutely on this report.
But on that report,
Yeah.
yeah. There are a couple of conditions aligned to that, you know, which is in between meetings, it would be possible that the chair and the chief exec and the finance director could approve several projects of 25,000, and there would be a sort of, I would call it a run on the funds. So we have put in a the chair and the finance director have spent it all. It's all gone. So we've just put in a few. That wouldn't happen, but now it can't happen because we've put in a reporting mechanism to ensure that it won't happen.
Yes,
Vicky, please.
Oh, Hilary. Yeah.
Oh, Hilary was first, was it? Hilary, sorry. Hilary, and then I'll come to you, Vicky, okay? Hilary, please.
That's all right. I was just going back to the TAF point, and I know we've moved on, so I don't want to extend that, but I suppose it's the same comment I made last time. On reflection, we should have been still seeing the existing TAF until this new one had finished.
Yeah, I agree.
And I've written that in the report.
Yeah, and it's in the minutes. Yeah. So I think that, you know, I can see from where you're coming from totally that, you know, as execs, you probably have been using the, sorry, not probably, okay, you have, but it's not reflected anywhere in the paper. So I think to cover that point off, if you reflect it in the minutes today, that is actually the case, then maybe we can close this point off and tell we're satisfied that the new TAF is.
I think that's a very helpful suggestion, Hilary. So we could capture that in the minutes. Vicky, please.
I was just going to make the same point. I think it's important that Matt's point, which is the management of any risks within the organisation, but actually that wasn't reflected through a current TAF, and therefore we couldn't seek assurance through that route. So it's just supporting what Gareth and Hilary have just said. Thank you.
Okay. Thanks, Vicky. Thank you. So we have discussed and noted the audit highlight report. And so now we come to the quality, safety and performance report, which is 4.40, which I'm just opening. This is again for noting and for discussion. Hilary, do you want to raise any? Hilary, keep doing that. Vicky, do you want to raise any points in relation to the?
Yeah, I mean, I think that take the highlight report as read, but there are areas of alert and escalation which is important to just pick out, because there were some emerging themes coming out of the QSP in relation to some of those bullet points set out in that first section. And we asked for that to be reflected in our risk register. So there was a number of concerns through either incidents, some of the referral processes and the booking processes that had led to incidents, concerns being voiced. So that triangulation of all of those issues was absolutely key. And the Cancer Service outlined in the committee that they were taking immediate make safe actions. Nick had chaired an initial meeting, and then that's with the Cancer Service to take forward. And we said as a committee that we'd receive a high-level strategic plan in the next meeting. So that's really important that the board is cited on that. And despite having a process where we're having an ongoing review of our policies, we noted the concern that 50% of our policies are currently past their review date. And whilst the extant nature of the policies still carries on, what we can't afford to do is take our foot off the pedal in terms of our updating of our policies to improve our rigour and governance. The risk register and the TAF, as Gareth has outlined in his summary of the audit committee, we've discussed that, so I won't go through that. But obviously the workforce issues and the additional action planning that was highlighted in the audit report, an action plan, and obviously some of those associated actions in the supply and shape paper are just there for your attention. So quite happy to have any questions or comments on that report.
Thank you, Vicky, very much indeed. I think Andrew's hand I can see up. Andrew, please.
Thank you. Just for clarification under advise, and this also was mentioned in the previous audit report as well. This is a private patient service improvement group. I didn't. It's probably my lack of understanding, but there was something here about a solution to facilitate timely and robust billing. And on the previous report, there was a statement that said, find it. It was about age of debt going from 1 million to 250,000.
Yeah.
I didn't quite understand what that was. Oh, there it is. Yeah, it's under assure. The committee acknowledged, this is the previous audit committee, the age of debt position achieved a reduction from 1 million to 250,000. And does that link to the billing issues? I just didn't quite understand what it all meant.
I couldn't. Right, I've got a couple of hands up who want to answer you, Matt and Nick.
Actually, probably do it far better than myself.
Oh, just on the age debt. That's not true. The age debt bit, it's just we have had an issue where we had cash that come in to the organisation not actually related to private patients, but the link between which individual patient that related to was not there without doing a lot of work, and that's why it's taken so long. Which does link to the other point about getting a system that makes sure there's a unique reference when the information from our patient services side goes off to the insurers. You can then tie back when we bill, then the cash receipt comes in that they use that unique reference. So it will avoid a pot of unallocated cash was sitting there. So we've been paid. We were saying our age debts were worse than they were. Right. But once we've done that linking and allocated, we can say, well, actually, all those debts were actually paid within a reasonable time, and they weren't aged. Yeah. It's only the 250, not this. Yeah. It does link. Get it right first time. We won't be getting that issue because we can make the link between the patient and the seats that comes in, and that's.
It's not in agreement.
It's taken a long time.
Exactly the same.
It's hard work.
And the solution should enable us to
yes.
No, that makes sense. The way in which we manage the process completely. Yeah.
So I think that I can't see any. Oh, Stephen, did you have your hand up, please?
Yes, thank you, Chair. It's just in relation to one particular paragraph in the highlight report, which relates to a discussion I initiated at the committee. I just think the paragraph is actually rather ambiguous and potentially concerning. And I just think we'd be helpful just to clarify it. So the paragraph is at the top of page 7. And you'll recall the conversation at QSP around the Civica survey and outpatient waiting times. So I don't know if you can see the paragraph there at the top of page 7, just below the first bullet point. It references patient feedback via the Civica system had signalled patients were dissatisfied with waiting times, and then it goes on. I'm just conscious, obviously, this is a public document, so we'll all recall, those of us who are present, what this actually meant. But one potential misreading of this is that the majority of patients are dissatisfied with the time they have to wait before being seen by cancer services, which of course is not the case at all. I just think it's worth clarifying that the Civica system, this was a sample of patients, and as we would advise, relates to outpatient waiting times. And of that sample, a proportion were not happy with waiting times. Now, the public would understand outpatient waiting times to mean, understandably, the time patients wait before being called into outpatients. But this conversation was along the lines of waiting times in outpatients. In other words, once a patient arrives in the outpatient department, how long they have to wait to be seen beyond their appointment time. And we did have a conversation around the fact that on occasion, some clinics run very much over time, and that is partly because we're bringing in patients as quickly as we can, and clinics are getting overbooked, which is obviously what we have to do to make sure patients are seen as quickly as possible. But we then got on to a conversation about to what extent we are or aren't monitoring overrunning clinics. And I know Rachel's on the call. I've been mulling it over since that conversation. I think I will drop Rachel a little line. I'd like to perhaps catch up with Rachel and understand how we are or aren't monitoring overrunning clinics. But I just think it is important, as this is a public document, that this is about waiting times in outpatients, which on occasions can be lengthy for the very good reason that on occasions extra patients are being brought into those clinics to make sure they're seen as quickly as possible. And it's not the case that the vast majority of patients are dissatisfied with how long they wait before they're called to an outpatient clinic. And so any reference to lengthy waiting times is about waiting times in outpatients, not, as the public would normally see it, outpatient waiting times. And it sounds slightly pedantic, but obviously there's a very big difference there. I just thought it's important to make that clear in a public meeting.
Thank you, Stephen. I think that point is well made. Nick.
Yes, just to come on to that, I think what was also clear is the question that's been asked is somewhat vague.
Yes.
And it's not very clear. And therefore, the work that's referenced in that paragraph is to go back and look at that to see, can it be clearer as to what specifically that relates to? And it was identified that some of it comes from the National Patient Experience Survey that we use, and that's currently being reviewed nationally as well. I just wanted to make that point.
I think that is a very important point. So is there an opportunity for us to change the question so that it better reflects what we're...
To change a national question.
So can
you back to look at with our own questions, can we make the change? But the national questions are set until such a time as they renewed, and that is expected to happen in 2024. So.
Okay, that point is also very well made. So Stephen, thank you for drawing that to our attention. That is an important clarification. It was about whenever you've already been referred, I've come to outpatients, and that section referred to how long I wait in outpatients before I'm seen, not how long I wait to be seen by the cancer service. Thank you, Stephen, for that clarification. We will note that in the minutes. Have we got time for a break?
Yeah.
So we're now going to have a 10-minute break. For a comfort break and to grab a cup of coffee. It is 12 o'clock now. If you could come back just after 12:10, please. Croeso nôl pawb. We now come to section 4.5, which is the performance management framework. This is, Kath O'Brien is not with us today. So I understand Rachel and Peter, you're going to lead on this item. So if you can take it that we've all read this report in detail. So hand over to you in the first instance, Rachel.
Sorry, thank you. Thank you, Chair. I guess some things to note from me. We've seen a significant improvement, which has been sustained in Q2 in radiotherapy, following a fragile start in Q1 when we had the introduction of the new more reported metrics within radiotherapy. So this is continued to be sustained throughout the rest of the year to date. Significant work has been done around training. We've seen the full rollout of the care path information system and some pathway optimization work, which has helped to deliver on this. SACT, similar position in that we have continued to sustain over 90% compliance up until Q2. Noting for both SACT and radiotherapy, one of the key areas for us, the challenges relating to workforce across specialties, and in particular we're seeing those challenges relating to pharmacy and SACT nursing staff. Formal processes continue to be in place in the form of multidisciplinary reviews to review performance or any performance that's outside of compliance in relation to infection prevention control areas and falls. And it should be noted in the report that we haven't seen any harm, so that's a positive recognition. Delayed transfers of care, numbers are small for us, but we are seeing a number of those relating to, in particular, repatriation back to health boards and into linking with social services. And that's a reflection of some of the challenges in the wider NHS system that we're experiencing. We are actively involved in the national work and submit our data into the national data set. The only other thing to note then is we have seen significant improvements in data quality following some of the challenges with the implementation of DHCR, and we're continuing to work on improving that going forward. I don't know if there are any questions.
You've been conflict maybe on WBS, Peter. Okay, so if we want to pick up on this first section, thank you, Rachel, for that. I want to prove to Nicola Williams that I was listening yesterday at our meeting, because what I wanted to say is I'm really pleased to note the improvement in urgent care radiotherapy timescales. That's really good to notice that, a significant improvement. But do we capture the patient harm which might occur for patients actually waiting 7 days? Now, I appreciate that not everybody waits the 7 days, because the 7 days is the target and you're reporting against the target. And there may be a proportion of those patients who will get their treatment in 2 days or 3 days, but we're reporting against a target of 7 days. And so for some patients, and thinking of the ones we discussed, which is malignant cord compression, waiting 2 or 3 days or 4 days can cause significant, irreversible patient harm. So do we capture the patient harm that might occur? And this would come into the kind of quality metric discussion that we were having next. Do we capture the patient harm that might occur whilst patients wait 7 days for an urgent referral for radiotherapy? Is my question. Nick.
So just two parts to answering that, and then I'll hand over to Jazz. So firstly, we do regularly receive reports, and I've seen two this morning via the DATIC system where there's been a delay, and that delay in the reporter's view, and usually it's the clinician that will report it, may have caused harm to a patient. We then do a harm review and identify, well, did that delay cause any harm or not in relation to the treatment pathway and possible outcomes. And the board will be aware that, we have reported some reportable incidents in the past on the back of that. So do we capture every single one of them? Then I would hope so, but I could not give that 100% guarantee of that. But anything that clinicians are aware of is reported through the DATIC system. But the wider question is, does our performance management system from service level through to board, because it should be, a triangle, is that sensitive enough to identify the key parameters and the key measures that would indicate levels of harm? And the answer to that is not quite yet at the moment. So the measure we discussed earlier this week was the emergency radiotherapy measure. So that is a target, but that target does not reflect the NICE guideline in relation to the spinal cord compression in treatment within 24 hours of being diagnosed with that condition. So we do need, and the work we're doing on our quality metrics is to really think about what are the other measures that are a real important harm and safety measure for our patients that are not currently captured in a specific way that would allow us to have a bit of a flag at any level in the organisation that, we've not got our pathways and systems right.
So we do need to look at that, Jazz, because I'm thinking, for an example, some patients need radiotherapy cord compression as palliative. Some patients will need radiotherapy for cord compression, which is not palliative, which is curative. In the meantime, while they're waiting 7 days, they might have irreversible fecal incontinence, for example.
So I think definitions are really important here.
Yes.
If there's a clinical diagnosis of cord compression, which is of significance, so degree of compression onto the cord, affecting other things like continence, that's emergency.
That becomes emergency, not urgent then.
criteria.
So then it's 48 hours.
And that is, and we are delivering 85% of those patients within 24 hours and 95% within 48 hours. So we are, if you look at the particular emergency radiotherapy cost, a defined target, then we are meeting that requirement.
It's sometimes as it can take 24 hours to arrange an ambulance.
Absolutely, but
so then you're half, and then.
But as soon as we are aware of somebody sitting in a health board and it's flagged, it comes into AOS, then all systems go. And so to achieve some of those targets that we are achieving is because people are working incredibly hard, plus radiotherapy planning, etc., etc. I think the criteria, the patient group that are within the 7 days that we're talking about may be patients at risk of who are in pain. So there are other categories that we need to then drill into to understand, how long have they been waiting, what's happening to the quality, what's the harm looking like. And so I think we've coordinated ourselves to a category which we understand meeting a kind of national requirement. But I think there is more work to do in understanding the palliative radiotherapy group and what's happening there. There is work happening. There is a palliative radiotherapy, Bevan exemplar pathway that we are looking to roll out. And Rachel will be aware of lots of work that is going in this space around palliative radiotherapy,
So if a patient is deemed to be emergency radiotherapy for something like cord compression, they'll get an ambulance as an emergency within an hour.
So there is a whole pathway for that. I mean, that most of the emergency radiotherapy is cord compression. We had 20 patients that were reported. Very rarely do SVCO, for example.
As was described on Tuesday, I think there are some challenges with that pathway and what is recognised by other colleagues in what categories. That's what the improvement project is trying to unpick really, and then identify the revised pathways that need to be put in.
So I think the more general point to make, and I call Carl in, is we have the target, which is in terms of days or whatever it is, but there are other issues that we need to be looking at, not just because that target, even if we meet it, can give us a kind of false sense of reassurance, can't it, about what the patient experience is like.
I think the point is that it's the time that we recognise the patient requires emergency radiotherapy. The patient could have been in a health board for 5 days waiting for an assessment. So actually, we may want to look at when was that diagnosis made in the health board.
Right.
And when were Velindre aware of it? So this is our target for radiotherapy, which is at the point at which we were aware of it being a necessity.
So was your hand up, Carl?
Yeah. I just agree with everything's been said. It's such an important conversation area of work, isn't it? Getting under the high level measures about how many did we do, how quickly we do them, so what. But I think there's a broader point, isn't there? And if you look across NHS Wales, it starts to get into 7-day working in the NHS again, doesn't it? Because ultimately, many of these procedures across all DGHs and everywhere else, as we understand it, not as available at certain times of the week, i.e. Friday, Saturday, Sundays, as opposed to when they are during the week. So there's a fundamental system conversation still, isn't it, to be had around 7-day working where appropriate versus improved safety and outcomes, because we know there's a whole range of reports which tell us that that is still a remaining issue for not just the NHS, but also the NHS as a family to try and grapple with. It's no different for us, is it? Because we do category 1 and 2 stuff on a Saturday. There's not many organisations doing surgery or diagnostics or major procedures on a Saturday or Sunday. So it's in that
so
space.
We would do the radiotherapy on a Saturday and Sunday. It depends on the patient getting to us.
Done on a Saturday, I believe, Jazz. Yeah, so Saturdays is a working RT day.
I mean, our surgery does happen.
Yeah, it does. Steve. Emergency, but it's a broader. There's a broader challenge for the
other parts of the pathway may not have got them to us in time. So, Andrew, unless you want to come back on that specific point.
No, mine's
or general. Andrew, please.
So this is related again to the radiotherapy targets, and particularly the key performance 15, which is about urgent symptom control radiotherapy, where we have some very low numbers, we've gone from 6% to 8% specifically on that treated within 2 days. So treatment within 7 days, that's pretty good. And we're talking about relatively small numbers here, 49 referrals, but 4 of them meeting 2-day target, or it's 49.8%. So then the question that got me thinking about what Carl was just saying, if someone is diagnosed Thursday or Friday days takes you into the weekend, but also is that target the right one? Is it our target? Is it a national target? I don't know specifically that 80% target within 2 days of referral for that group. You know, if we're less than 10%, then is the target wrong, or is this something that we could genuinely?
These are the cost targets, I think, aren't they? Sorry.
Yeah.
So they are national.
Yeah.
In that sense, Andrew. But yes, your point is well made. Matt, please.
So I suppose the important point is the one I made on Tuesday, which is the point, Chaz's last point, when the patient's in a health board, sitting in ED, for example, where often initial diagnosis may or may not happen. It may not happen vet because they haven't got the specialist oncology input, which is why we invested in the acute oncology service through the business case. That may not be fully implemented yet, but the aim of that is to give that specialist access to oncologists who would help, I guess, diagnose these patients as being.
Absolutely.
And so that gap is the gap, isn't it? That where the patient's not actually getting the diagnosis quick enough.
If you were to process map this, there are lots of points where you could fall through the cracks, and I think that's the point you're making, really, and that's the point I'm making.
And that was the basis of the AOS business case. So a very big part of the fact that we got that over the line was to address it. So I think it would be useful to have some facts on how we're doing now compared to 5 years ago even. Because I suspect we are doing much better than we were doing, but there's still room for improvement. I think the generation of the IRMA, which is the point at which we probably start the clock, happens as soon as we know that patient. So we often do it in the AOS meeting before we see a patient, because actually we want to get the planning slot in. So I don't think could do that any quicker. It's about the pathway that is ahead of that.
Should patients, these kind of patients, have to wait? Get into too much operational detail now. Should they have to wait for the MTD meeting for that diagnosis to be made?
Well, they need to be. I think the diagnosis is made in the health board within a scan. It's the point of. It's the point of referral, I suppose. So it's a that meeting clearly runs one Monday to Friday, and then on call for Saturday and the weekend. So I guess we could. The question would be, how else would we do it? At the moment, that's what works.
I suppose what I'm looking at is what does the pathway look like? And some parts of the pathway we're not particularly responsible for, but we're worried about the patient. Does the pathway look like? Not simply the emergency target, which is 48 hours. What does the pathway look like for the patient? How long were there delays in getting the diagnosis? Were there delays in getting the patient transferred? I do know that once patients enter into our system, that they'll be having the radiotherapy within minutes, just about. But the pathway, and we might take a false assurance from seeing that we're compliant with the 48 or the 7-day target. We might feel all right, but that's all working. Like in terms of the pathway, it isn't necessarily.
I think it is a measure of that starting of the clock to when we are doing our business, and that's what that measure is telling us. But it's not necessarily reflective of that patient journey.
So I just wanted to raise that. And I'm just wondering, are they more sensitive?
Which I wasn't at. So, it'll be. I think we need to have a look at some of those facts that were presented there and sense check them.
But the more general point is, targets, it turns out, can be quite a blunt measure of what the patient experience is actually like. Which is the point you've been trying to make to us for a while.
Safety measures within that suite that align with standards like NICE, etc.
So thanks, Nick, for that. Now I've got Vicky. Or do you, Rachel, do you want to come in on that one specifically? It's Vicky, Stephen and then Rachel.
I was only going to say there is work ongoing that has been part of the Safe Care Collaborative, but actually is wider than the Safe Care Collaborative, looking at this particular pathway, looking at how the patient comes to us, the challenges and the areas that we need to address to improve that pathway. So that work is happening.
Thanks, Rachel. Thank you very much for that assurance. Vicky, please.
I just wanted to raise a query really on page 43 of 69, which is KPV 11, which is the patient donor experience, because I don't think this is reflective of our true position, because it says for your Velindre experience has been read since February 23. So I'm sure there've been actions taken. We've got assurances coming through to QSP in terms of the learning from patient experience. So just wondering whether that's just an inaccurate reflection and hasn't been updated.
Which is 43. 43. Thank you. Who's going to take that question from Vicky, please?
Richard, just to say that's also picked up on page 8 of 69, where there's a statement that 2 patient satisfaction surveys, one of which is, would you recommend this? 95%. And the second is your Velindre experience, 63.
Yeah.
So I think it's the same point, Vicky, but I was going to ask about that because it seems fairly low against a target of 95%.
Yeah, that's who's going to answer that, because I've got that one down as well. Here it is. It's 2.5. Is where patient experience in the cancer centre appears low, 63%. And I just wondered that I read it correctly. And I think that's what Vicky's asking as well. Yeah.
They're two different questionnaires. So the Your Velindre experience is a very comprehensive, lengthy questionnaire which fewer people respond to. And then the would you recommend is just the shorter one. So we ask people to complete that, and then would they like us to give some further feedback. But I'll bring Rachel into the actual outcome and what action's being taken.
Rachel, did you want to come in there, please?
I was just trying to find the page. Which page are we on? Oh, patient experience.
2.5.
And the chart on 43 of 69.
43 of 69.
Right.
It's also in the preamble as well.
Right.
What the report does say is that there was 8 respondents to the Your Velindre experience. There's a very small sample number given the size and then the volume of patients that go through the service. And actually the responses were all 8, 9 and 10.
Yeah.
So it doesn't seem to equate to the 63% that's been put in so that there may be a data transfer issue there.
It looks like they're going to the 9 and 10.
Say, that would we haven't picked it up, or it hasn't been flagged. I wonder if it is a data transfer, because this is information that comes from Civica, isn't it? And we haven't been in the space that it's been a challenge for us. So I wonder if there is a transfer data issue here, and we can go away and look at that for you and come back to you if that's helpful.
Yeah, that'd be really helpful. Thank you.
Thank you, Rachel.
I don't think the measure itself is helpful as it's worded. We need to look at that as well.
So that's 2 actions that Rachel will have a look and maybe come back to us, and Nick, you take a look at the wording. Not in any way to be defensive, but to make sure that we're understanding properly what the data's telling us. Gareth, please.
Thank you, Chair.
Are you making a different point?
I am.
All right, because I've got Stephen, Rachel, and then can I come to you? Sorry, I thought you were going to make a point in relation to that.
You took Rachel in.
So Rachel, we've done you now, I think. Stephen, please.
Thank you, Chair. I just wanted to make a general, I suppose, observation, or it's a repeat observation, which is similar to observations I've made previously about the very nature of these reports and the assurance from it, which is around what I would call the framing of these points being made. So can I just use one to illustrate it, which is on page 5 of 69, under heading 2.1 Cancer Service. Cancer Centre Service Overview, the third one down refers to compliance with the 21-day time to treatment target for new patients referred for treatment with SACT. I don't know if we can see that one there. I say it's third paragraph down, page 5, under 2.1. And what the paper, in one sense, actually reports is that there was said it decreased marginally in September from 90%, to 90% from 92%. Now, you might recall I've made this point previously. The way these reports are framed is they've focused on compliance, and very often there are high levels of compliance, which distracts us from possibly meaningful levels of non-compliance. So I can reframe that paragraph there, that compliance, we change to non-compliance with referral for treatment SST, increased significantly in September from 8% to 10%. That's the non-compliance. In other words, the non-compliance increased by 25%. So I'm just making the point, which I've made previously, is it's very often the framing of these reports where we focus on compliance distracts us from a discussion about a potentially significant increase in non-compliance. In the case of this 21-day time to treatment target, it's a 25% increase in non-compliance, from 8% to 10%. So I'm just making that as a general observation, because I do feel we get a little bit distracted sometimes from what needs to be part of the conversation. I know previously we've discussed this and the response has been around, well, we need to be focusing on the positives, etc. And this is historically how these things have been represented. But I would make the point then, if we were going to be completely consistent, that we wouldn't be reporting 5 or 6% staff absence on sickness. We'd be reporting 94% attendance of people who are not sick. But in that case, with sickness, we look at the level of sickness, if like the non-compliance side of it. So I know I'm not going to change anything, but you know, it's one of my little hobby horses, and I just didn't want to miss the opportunity just to illustrate the point I've been trying to make previously, using this example here of the 21-day time to treatment target for new patients referred for treatment with SACT. That's all I wanted to say. Thank you.
Stephen, you have made the point before, and just if we can encourage our exec colleagues or those who validate the papers coming to us, that I used to say to students, you know, if they got a 50% good response to something, they'd say 50% of people say this is great, and I would say, well, that means 50% of people think it isn't great. So if you can look at it from both ends when you're putting reports in going forward, I think that would be reassuring. Carl?
Yeah, I always agree with Stephen. He speaks a lot of sense, doesn't he? So I think we need to deal with both. That's the obvious statement to make. Yeah. Just as a point of fact, though, some of these targets, the way they describe, whether we agree with them or not, are national set targets. Same as Sarah mentioned about. So whether we can still use them to have a different narrative and discourse. I agree, but some of the titles as they are. So how we use them is up to us, isn't it? But I'm just saying that. Just as a matter of fact.
The results are our results.
Exactly. So this discussion we have is the most important bit about what we're doing to improve, rather than and that's the point that Stephen was making.
I think so. Thank you, Carl. Gareth, please.
Thank you, Chair. I was going to go to data quality, which Rachel mentioned has improved. Again, to some extent, the same point, with that being relative, we don't know, but the narrative in the report still says we're causing the issues related to implementation of the DHCR continues to cause significant administrative challenges across Velindre Cancer Centre. And this has been going on for some time now. And I suppose in simple terms, I'd like some assurance as to what we're doing about it. And
so who's going to answer that for Gareth, please? Good spot.
Well, I can give bits of Jazz perhaps, and perhaps we might want to pick it up as well a little later on. Carl Taylor is with us for Bex, because there's a number of different dimensions to this, isn't there? So Kath is the SRO, so she's deep into the detail. The first thing I think Jazz may want to help on was the fundamental change in the ways of working. So that is significant in terms of going from the way we went about business. So there's still a bit of a relic of that. There's some other things then related to data input. So we had a lot of QA going on because some of the functionality wasn't resolved. I believe now, Gareth, that is broadly resolved. And the last point then was the need to get on with phase 2, which is in the planning stage, because that will then address some of the functionality things where we had, and it's not a minimal viable product, it was phase 1, give us this level of function. Phase 2 will address that, but I think, and Rachel might want to comment as well, there's still a view that because of some of those, both ways of working and changes, it has increased the administrative burden on some of the requirements of the system. And Rachel would want to come in there, but Carl Taylor can go into more detail this afternoon, because we were discussing this very matter yesterday, actually, about what point do we try and close it down and move forward as service, because I take your point, it's been there. Rachel.
So Rachel, is your hand up to respond to this point? I got somebody trying to.
Sorry, yes. Yes. You want me?
Did you want to come in on this point, Rachel?
Okay. So sorry. Yes. I was going to say. I support what Carl has said. We have also done a significant amount of training, because some of this, the DHCR was also linked the introduction of the new radiotherapy targets, and the significant amount of training that's been done around how you categorize patients into those 4 categories has taken place, which is where we've seen also huge improvements in data quality because of that work on the ground. There are challenges still with resource. It is a more resource intensive system in some areas than the previous CANISC was, and we have been working with our teams to understand what that exactly means, and potentially opportunities to do things different to address some of that. And again, as Carl said, there are a number of elements that are linked into the next phase of DHCR, which again, we're working with Carl and his team to prioritise up into the national programme.
So people, right, Gareth, you want to come back, I can tell.
I think we need to revisit it this afternoon when Carl Taylor is here, because just the gentle challenge back is that a new solution shouldn't be more resource intensive. We should be reducing the level of.
Yeah, no, I agree. I mean, I'm sort of sorry.
And also timeline. We need some assurance behind timeline.
So we note the concerns that you've raised, Gareth, and we note also that we will, as a board, pick this up this afternoon, and then we need to report back to this board on that matter in next meeting.
Yeah, just to be clear, digital bit, we want to complete this because our job is done in this respect. So I agree entirely that we need to conclude it and then move on to phase 2. There's a challenge on funding for phase 2, but that's for
That's not to the conclusion I just made, then, I think, Council. So that's right. Okay. So I don't have any other hands up. I was going to, Richard, is your hand to come down now? You've got a new point. Just come down. I was going to ask, before we move to WBS proper, why does WBS report compliance with 30-day targets for putting things right and complaints and so on, and the Cancer Centre doesn't? I've asked this before, just to be consistent. We get a report from, we get it in the QSP in various reports, but in this report we always get, in this performance report, we always get the compliance, the 30-day compliance for Welsh Blood, but we don't get it for the other division. And should we? Rachel.
Just looking at, isn't it KPV 12?
It's in there, I missed it, it's in a table, is it? I missed.
Complaints received and putting things right within 30 days.
Yeah.
That's the target we're looking at. Yes, we're 100% compliant against the 85% target.
In both divisions?
For VCC I'm looking at. I don't know WBS, I'm just looking at the VCC one.
WBS is 100%.
We've got two different authors. One highlights it, the other
Doesn't,
but it's
yeah.
reported in detail in the content that comes later. You all pick it up, report it, but VCM because it's 100%.
Well, it's 100% of Welsh blood as well, which is good news.
Yeah.
That's really good news. Just, okay, no other hands up, so. Oh, Nick, is your hand up? I didn't see it.
Taking it back down again. I just need to check. Will you refer, does the WBS one include the incidents?
We also talk about quality incident investigation.
Yeah, so I think that's where the variation lies.
Yeah, yeah.
Rather than just concerns that we should be looking at both.
Peter.
Okay. So Alan and I went through this yesterday evening, so just the highlights, but we'll take questions afterwards. So first of all, demand for blood and platelets continues to be met. There was strain on negative blood demand we had. We're still seeing very uneven patterns of demand. So we did issue blue alert at the end of September, but we recovered that internally. We didn't have to request aid from any of the blood services. And that does have a knock-on impact, though. The challenges around the predictions of demand and the very wide variations in demand mean that we're having to focus on pulling in the right donors of known blood groups to donate, and that takes quite a significant amount of resource away from the recruitment of new donors. So that's something that we're very conscious of, and we're trying to work through, because our new donor recruitment slipped this month.
And that might turn away. So you call them non-donors here, but I think they should be called new donors.
New donors, yes, that's what sorry, that must be a typo.
Oh, okay.
Okay.
So if that could be changed to new donors.
Yeah. So it's just for people to be aware of that. The new donor recruitment is something we need to focus resource on. Similarly, stem cells, the collections are strong and increasing. But again, we've got to focus on getting the new donors in. It feels if we're not careful, 2 or 3 years down the line, we sleepwalk into a stage where we don't have sufficient people on the panel. So that's why we have a medium-term project.
Could you perhaps explain to Peter, we've moved now from blood into stem cell, which is part of bone marrow registry, so that everybody understands that you kind of changed.
So the two key collection services that we offer, whole blood or whole blood components of platelets, and that is a regular donation cycle. So we try and get people to come in 2, 3, 4 times a year. Stem cell collection, so this is bone marrow transplants. So that would be something where a donor may only donate once, possibly twice in their lifetime. With stem cell donors, we know that the best clinical outcomes are from donors below the age of 30, although you can stay on the stem cell donor register until the age of 60. And depending on the availability of tissue matching donors, it may well be that older donors are the best option. But stem cell donors we routinely collect through academic establishments. So when we're visiting Freshers Week and universities, they're great places for us to recruit both blood donors and also convert some of those to potential stem cell donors. Increasingly in the last year, 18 months, we're now also offering people who don't wish to donate blood the opportunity to put themselves on the stem cell register. Instead of taking blood samples for typing, we take cheek swabs from them. And that's the focus for where we will build those donors.
Yeah.
But as a donor recruitment is something that is on our radar and is something that we're looking very carefully at. Quality markers you've referred to already, Chair. So in terms of incidents and our donor feedback is all scoring very, very highly. I should probably just call out we had one externally reportable incident which related to a donor who had previously lived in a malaria endemic area which hadn't been picked up on their screening. And I would call out our clinical services team, who were excellent. They actually visited that donor in Nottingham to take a screening sample, which has come back and confirmed that the donor is not carrying malaria. But it was it was something that we had to do for completeness, and I think it was a really good example of the way that our team step up when we need to. Other than that, are there any other questions?
Peter, I think it's a very good, excellent report in the round, obviously, and we appreciate the difficulties of, balancing wanting to accept all donors and getting the blood groups that you actually need at the time. At the top of page 5 of 69, you move into the quarterly performance for deceased donor type being cross-matching performance. And again, I'm not sure that although the board is, that's a real swing now. And what we're talking about here is the SNODs, I think, the Special Nurses Organ Donation.
Special Nursing Organ Donation.
Are not employed by us.
No, they're employed by NHS.
Or by the health boards. They're employed by NHS BT.
Yes.
So that's sort of.
And so as a response to that, we're in the process of setting up a forum for us to meet with the SNODs on a regular basis, right, so that we can refine the services, because some of those turnarounds have been around not understanding how the two services work together.
Yeah, yeah.
So I think that there's just process points of friction that we can deal with to prevent that from happening in future.
I think the point I was making is to the kind of uninitiated, it may not appear that you've kind of changed tack completely, gone into a sort of different service, in a way in the report. But I commend you for the work that you're undertaking to make sure that there's a seamless service between the SNODs, which is a dreadful an acronym, isn't it? And our service. Pardon?
That's something for his dark material.
It is, but that's what they're called, SNODs.
Yes, well, that's the acronym, and we do love an acronym at the blood service, as you know.
50.
Well, one of the points I was going to make at the end of the meeting, I may as well make it now, is I think we've slipped a little bit in setting out what our abbreviations and our acronyms mean. And they are two different things. An acronym isn't an abbreviation, an abbreviation isn't an acronym. Can we please, those of you who are validating papers that ready to come to board, make sure that there is a glossary of abbreviations and acronyms. There were quite a few in this meeting where those glossaries weren't there. Nick had a hand up, and then I'll come to you, Gareth. Nick, please.
Yeah, thank you. Just to let the board know, I spent some time with a few teams yesterday afternoon in the blood service, and a number of them described to me, the inordinate effort and energy and passion and enthusiasm that their teams took to resolve the blue alert issue, really. And that was from the donor contact team through to laboratory staff, and it's a whole scale effort, with daily meetings and trying to make sure that we maintain the blood supply for Wales, which was commendable. So I think, Peter, whatever we can do as an organisation to try and, I know you can never get a stable demand and supply, but because I think it does tip everybody into a very different way of operating, and then the business as usual stuff, sort of some of it has to wait, isn't it? While that's
there's some unintended consequences.
But it was amazing for me to hear, from staff at all levels about we're doing everything we can now to make sure that we got this blood supply, and they all understood what their role was and how they needed, how they needed to put that effort in.
Thank you for that. Can we make sure that acknowledgement is minuted? I think that's important, that we acknowledge in the minutes what you've just said, Nick. The point is that when you move into emergency mode like that, you solve this problem, but there are unintended consequences somewhere else, and it's just trying to manage both, isn't it?
Absolutely, and I think there's more effort that I need to put in with the business continuity team to make sure that we're learning the lessons what I'd rather we were doing was putting the Herculean effort in to prevent us going into a blue alert.
Yeah, okay.
And to recover from the blue alert. But that's just me being a quality professional. We prevent rather than mend.
I think that's please. Thanks. Gareth, now please.
That's a very neat segue into my question, which is what is a blue alert, please?
Oh, right. I thought I was picking out all the ones that people wouldn't maybe get.
Mindful that there is a paper later on in the agenda that does away with the term blue alert.
Yeah.
But at present, we have a colour coding system. So obviously green would be hospitals can order the blood that they need. A blue alert is for us to say to a hospital there are certain blood groups which are currently at borderline type supply levels. Right. So if we see large orders coming in, we may query whether you actually need that. Is there a patient waiting for it, right, or are you putting some stock in just in case? Like it's if you like a coded way of saying to the hospital you might need to have a conversation. An amber alert, which would be the next one, is where we may be saying to hospitals there are shortages, we may not be able to supply in certain groups, and then decisions may need to be taken around prioritisation of patients. So elective procedures may be delayed. I've been here 5 years, we've never issued an amber alert, but the blue alert is a very, very useful way of making sure that we don't put our frontline staff who are having the conversations with their counterparts in transfusion labs in the hospitals in a difficult position, because both know that actually there's a reason for conversation sometimes. Again, the other thing that goes with the blue alert is that we ask hospitals to look at where they could reduce their inventory levels temporarily to help centralise the stock, so it helps us to move stock to the place where the demand is. Okay. But we are unique in Wales in having that terminology, and hence the paper. Sure.
And just last question: is the blue alert threshold, is that an arbitrary threshold for different products that we set, or do we communicate that out?
No, so the blue alert threshold is agreed, and it's managed at blood service and the Blood Health National Oversight Group level. But as a rule of thumb, we would aim to have 3.6 days or more of a blood group in stock. So if we drop below 3.6 days and we don't see an immediate prospect, a large collection coming in to resolve that, that's the point that we would consider issuing a blue alert. It's not automatically issued. It would always be an SLT emergency planning decision whether we have to issue that.
Okay, thank you.
Thank you, Peter. Any other observations in relation to WBS? So the rest of the report, we've got nursing and quality, patient and donor experience, we've done digital services. I think we've discussed some of the digital services. Carl, anything else?
No, it's pretty simple.
Just bounced up the line. Estates and infrastructure. Any points you want to draw out there?
No, again, that's the report. I mean, obviously the carbon target is one we'll perhaps come back to after Christmas, just to let people know where we are. Broadly going well.
Thank you. Thanks, Carl. Matt, anything in relation to finance you want to raise here?
Just do it as part of the finance paper.
Yeah, I thought you might say that. But yeah, okay, that's fine. And then we've got the Gareth, please.
Sorry, Chair, thank you. Just one point of detail, please, on the finance section. On page 10 of 69, in the third paragraph, in the first line, we referred to capital expenditure limit of 24.516 million. And then in the third line, it refers to 24.416 million. We just need that figure to be consistent, whatever it is. On page 10 of 16.
Yeah, no, because it's out by 100.
Yeah, so it did.
100k out.
So, and I've got a question, if I may, which is on estates as well, Chair. Can I just mention?
Yes, of course.
On page 13 of 69, the right at the penultimate row, we have number of health and safety incidents recorded. 14 is the actual. And the baseline in March this year was 15. So we're at a pretty consistent level, but the target is 0. And just trying to understand whether we have some visibility as to why they're so high, and why we're so far off the target.
Going up. I mean, it's an interesting point about the targets, but an ambition versus a realistic target, isn't it? So our ambition is always to have a 0. Funny enough, I chaired the Trust Health and Safety Group yesterday, and this is part of the conversation about targets versus the chair's point about improvement. So I think we'll go back and reflect on that, because reality is, despite best efforts, we're unlikely to ever be able to achieve a 0. In terms of the overall numbers, though, and again, I think they're relatively small. That sort of, if you look at 14 across the whole organisation, with around about 78 of the staff. And the other point which you don't get, you but QSP get, is the breakdown of those numbers. There's nothing in there. There was one reported riddle, I think 2 months ago, but other than that, they're broadly speaking, slip, strips, falls, all those things which we still want to iron out. But there's nothing which is concerning the health and safety group as of yesterday, but anything which is really underlying. But I can certainly pick that up at QSP the next time around, so we go into some detail on the report there.
Yeah, thank you, Carla. And I think the linked point then is how many claims arise from the H&S.
Yeah, well, I could give it update, only because it was yesterday, so I chaired it yesterday afternoon, so it's quite timely, and Nick, we want to come in. So Jane Rabbiotti attends to that group, so at the minute there's one claim for health and safety issues. So again, that has consistently but gradually fallen. I mean, these things are all subject to, but there's one outstanding claim at the minute related to a health and safety matter, around about 19,000 claimants. So yeah, okay. Just good timing actually, because it was yesterday afternoon.
Lucky.
Yes, I am lucky, I'm going to be honest. So it's usually not that, doesn't quite work that well always, does it?
Thank you. Thanks, thank you both. Sarah, do you want to comment on any of the workforce data?
Yeah, just in relation to the absence levels, Chair, so we can see here the data to September. I can actually report that the rolling absence level to the 20th of November is actually 5.61%. So just to give us a more up-to-date figure, and obviously what we're seeing at the moment now is that we are seeing some absences related to COVID, but that number isn't increasing significantly, but we're obviously managing that in the way we manage other respiratory conditions now as guidance, and continuing really that focus on absence in its most holistic sense in terms of well-being more generally.
Yeah. Thank you, Sarah. Any questions or queries for Sarah, please? Anybody want to raise anything in relation to the performance management framework and the report that are contained in it before I move on?
Sorry,
Gareth.
one quick point again on finance, which is on page 15 of 69. In the purple section, which the trust expenditure on bank and agency staff against target budget profile. I spent a lot of time last night trying to get my head around those figures about 0.5 million and 0.117 million, as to whether they are meeting the target or not. And
spotted this in the QSP and asked for it to be corrected. It hasn't.
Okay.
So it's a number of things. It's like deja vu of being in QSP and they've highlighted stuff and it's not.
So what should the actual, is it, it's not 0.117, is it? Oh,
no, I mean the target was 500 for the year.
Right.
So we're breaching the target, so it didn't make sense.
It's meant to be 1.1, is that what you said in QSP? I think it's meant to be 1.1.
1.17.
Yeah.
I did say it's not factored through.
The big discrepancy.
Yes.
1.17 million
to.
Oh, no, the actual, this is,
Sorry.
the issue is to do with, this is reporting in an in-month position, and the target doesn't reflect an in-month position. I think it's that, yeah. The 117k will be what we spent in month.
September for what?
Snapshot. It's still breaching the target, but it doesn't make sense because we got an annual target, and 1 month actual. I'll dig out exactly what I said in the minutes for the QSP, but yeah, it's.
I was trying to work it out.
Yeah, no, when I was reading the QSP papers, it was confusing me, and it sort of made sense when I looked.
So we've confused you twice now.
Yeah, well, it's my fault. Yeah, it filters somehow back to my team's correctly.
In relation to performance management framework then, we requested to note this report. We've had a thorough discussion about its content and the detailed performance analysis which is provided in it, the PNF scorecards and the supporting data analysis and the templates which are set out in appendices 1 to 3. You all noted the new style performance reports which are continuing to be developed by the project group, the number of potential new measures currently under consideration. We'll correct the finance report that has just been highlighted. We'll acknowledge the contribution that staff made in the Welsh Blood Service when we get into a blue light situation. I'm trying to think if I left anything else out in relation to that, but I will listen to the recording, and if I have, I'll include it.
Sorry, Chair, how alert situation rather than blue light situation?
Alert. Oh, yes, because by the time it gets to the minutes, we'll have the new terminology. Yes, thank you, Sarah, for that. Oh, did you say one? Oh, sorry.
No.
And we'll have a discussion in part B around some of the digital.
Well, I think it's when Carl's going to come back.
Did it come in private? Yes, yeah.
Yeah, so part B is out. Okay.
Private is just doing something.
Right, colleagues, we have visitors outside who joined us for lunch. They're part of Nick's team, put together the nursing conference, which was, gosh, what was that? It was early summer. Spring, even.
So my team, it's representations from the conference planning group.
Yes. Yeah. Okay. So I'm suggesting, as they are here, I'm going to suggest we break for lunch now. It's 1:08, and I'm trying to think what time that we should need to come back.
Should we say
1:40?
1:40, yeah.
If we could come back, please, by 1:40, and please join our colleagues outside for lunch. They did put together for us a very interesting, contemporary programme last May. It coincided with International Nurses Day, I think, didn't it? That's right. And the whole issue of psychological safety was really examined very carefully. And I think there's a lot of insights have come from that, Nick, which the team are taking forward. So I invite you to meet them and have a chat outside. And I'll see you back at 1:40. Colleagues online, we'll have some lunch, and I'll see you back at 1:40. Prynhawn da pawb. Thanks yn ôl unwaith eto. We're continuing with part A of the meeting, which I would like to finish if possible by about 2:30 this afternoon. We come to point 4.6.0 of the agenda, which is the financial report for September 2023. And I'm going to hand over straight away to Matt to take us through the report. Thank you, Matt.
Okay, thanks, Chair. Assumption is you've read the cover paper, the detailed paper, and the appendix for TCS report. 3 areas I'm going to highlight are firstly the KPIs, the 3 KPIs, which is in section 2.1. And I'm going to talk a little bit about the Cancer Services Long-Term Agreement Income Performance, section 2.2. And then finally, the All Wales NHS Financial Position is also in section 2.2. The trust financial risks, which are in section 2.7. Going to the first point then, in terms of the 3 KPIs, I can confirm that we are still on track to deliver our revenue financial balance by the end of the year. And we're on track to deliver our public sector payment performance. As you see from the table, the capital expenditure limit is showing as red, as not on track. But that's because we are still awaiting the funding in relation to certain project management resource from Welsh Government. I had a meeting, as I said, I think in the QSP committee that occurred last week or the week before, where I explicitly asked Welsh Government about that funding, and they confirmed that that money was earmarked for us in their plans. So I'm confident it will flow, it just hasn't yet. Those are the 3 KPIs. So by the end of the year, my expectation is they will all be green. Moving on into the second point I said around contract income performance, specifically around the cancer services. So it links to a bit about the conversation earlier around digital healthcare record. If you remember at the beginning of the year, we were concerned that some of the activity wasn't being captured because of the change in the system. So we knew specifically what was causing that. So based on the thing that we knew, we've basically sorted that problem. So I can say from that point of view, that activity is being captured and now obviously collected in terms of income. That doesn't mean that there's still not teething problems, as we've discussed around process and time in terms of using the system. But very much around the income capture, it's resolved the issue that we had. So then moving on around just the All Wales financial pressure. So you all know that Welsh Government communicated with the whole of NHS Wales back in July. Health boards were given targets to identify further savings, as were other organisations that weren't in deficit, including the Trust. We submitted all those, we're delivering, so are the health boards against those. To sort of crystallise the whole position for NHS Wales finance this year, Judith then sent out, based on the work they've done with Welsh Government budgetary-wise, it's clear there was a massive gap on the health budget and they had to see how they're going to reshape the budgets in NHS Wales. A letter then came out more recently in October from Judith to each health board, setting out their new target in terms of their deficit positions, and with a 420 million funding that they secured from working with other departments in Welsh Government and reshaping budgets into NHS budget. So that all the health boards have got those new targets, deficit targets, which reflect the 420 million, reducing the 650 odd million deficit.
Yes.
And they're now all working to deliver that revised target position.
Matt, in relation to that, we made the contribution that we made initially.
Yes.
Are we looking to make any further contribution?
There's a number of things we're looking at. So we talked a bit when shared services were here, didn't we, earlier, about can we expand the medicines that they might be able to provide for the units. That's definitely stuff in the pipeline. I think there are some other cancer drugs, so they may not land this year, but obviously we're actively working with them on those. We're doing the normal sort of grip and control. What we just mean is getting back to basics and making sure that we're reviewing all of our non-pay expenditure costs, and there aren't any areas that we have not had the attention they need, and people are spending where they don't need to. So it's all that basic stuff that's important. It doesn't create loads of savings, but it's the right culture in terms of making sure every pound is spent wisely. I suppose in terms of the bigger ticket items, we've already done the stuff around the income protection, so they've had that, which is a big chunk. The energy price reduction is going to go back to Welsh Government across Wales, so all the organisations will be putting that money back into the system.
Right.
Because the price has dropped, obviously, as you know, in terms of energy bills. So there isn't anything specifically extra at this point, but I'll bring it obviously back through for sign off, and we're going to officially give money back to the system.
So have we were meant to have a meeting with Welsh Government officials in the Trust. Has that happened?
No, it's one of the things I've chased up. I had a meeting with one of the officials, so the Deputy Director of Finance for NHS Wales this week. And I did flag that as a point that he's going to take back to Hal Jones. And they said, well, hang on, I thought when that letter came out in October from Judith to the health boards, we would then have our meetings. I think they've still been wrapped up in trying to follow up on that letter with health boards because they're the ones in deficit.
Yeah. And
it still concerns, in terms of where we meet the targets, and they need to make sure they're getting that assurance from health boards at this point in time.
Okay.
Right. For the board that I'm chasing down because I want to meet them. There's a number of things I want to talk about in terms of how they help us the next 4 or 5 years manage our transition. And I know Steve's had the same conversation with Judith. So we need financial package, don't we? A plan the Welsh Government help us to manage all of the various risks that we might have over the next 5 years.
Yeah.
Until we get to a more stable position in the new hospital, because we're going to have transition, double running, all the things that will create issues for us to manage.
Okay, that's fine.
So that's where. And the third thing then is, I suppose we picked up some of that financial risk I've already mentioned about the ACR. So the paper still says there's a small 500k risk. What I'm telling you now as a board is, as far as I'm concerned, that risk is gone in terms of the capture for income collection. And then there's a few other risks in there that we're flagging around some of the other cost pressures that might land this year, but probably part of that transition stuff. I'll just take any other questions, really. I mean, the details, in the reports.
Yep.
For you to read.
Thank you, Matt. So the very good point to note is that we're on track to meet both our statutory fiduciary duties by year end.
Yeah.
So that's really good news. It's been a tough year. It may be a tougher year next year. I'm not quite sure, but that's really good news. We're waiting for the discussions about further contribution to the NHS savings. Does anybody want to raise any issues in relation to the reports and the appendices that Matt has provided? Did I hear somebody wanted to raise something to do with agency costs? Or you did that with the report in the performance management? So that was covered off there. Thank you.
Correct in the actual paper, because it's obviously probably wrong in the actual paper. It is the fact that the target is wrong. So the monthly target is actually 50,000 a spend, and there's a zero missing. Yeah, and there's a zero missing. That's why it doesn't make sense. So we're actually in red because we're spending more than the 50,000 a month. It's not 500,000. Someone's missed out the zero. Yeah. It's just Steve, my team member who came in at lunchtime in this case. And I don't want an explanation, obviously, in terms of why we're spending more. It's all to do with making sure we're trying to cover gaps either in vacancy or sickness. But just to assure you, it's still a lot less than, I say a lot, nearly 400 grand less than last year. So we haven't gone back on what we were spending last year, so it's still below the agency spending last year.
And there's a proportion of our budget. It's quite a small amount, isn't it?
It's small, but it's largely, as I said, clinical areas like medical physics, where we know, we've talked a number of times, haven't we, about the risk of gaps. Our medical physics team, radiotherapy team. Yeah, so it's being spent for the right reasons to make sure we can deliver our capacity.
Sure. So is there? I'm just speculating out loud now, thinking out loud. If we're able to recruit,
different labour market and clearly the cost that the incentives they have in having this agency rate rather than substantive.
So, sorry, does that mean we're spending about 1.4 million a year on agency?
Based on what?
Yeah, I'm just taking that one.
Yeah, it's probably in that realm. I think the detailed report's got the actual.
Yeah, the details. It's come down. See,
it has come down, but it is below last year. But it wasn't what we planned. We were hoping to improve more. But ultimately, it depends on the vacancies and the sickness. That's what drives it. And that's why when we do the triangulated report that Vicky has in the QSP, that's why we always link the two, because that's what's driving it, the sickness and the vacancies.
So have we got an analysis of what the saving would be if all of those people were employed with the trust rather than the plan?
Premium's probably about 400 500k is what I've worked out. So that's the size of the prize that we're always aiming to get. You know, we can get down to no agency. It's a nice little improvement in terms of our bottom line, and that can be invested in actually more substantive stuff. But whether we'll ever get there depends on the labour market. Yeah, Sarah will tell us a lot about that if we get time.
Not spending on, well, we should, a bank and agency spend on nursing staff should drop as international recruits become embedded in the organisation. That should.
It's not a big area of agency though.
It's not a big area, no, it never has been, is it?
No.
No. Just looking around. Anyway, so if there aren't any further questions from Matt, we're asked to note the content of the September 23 financial report. And as I've already stated, the year-end financial performance, which at this stage is reporting a break-even position together with above target compliance on public sector invoice payments, both of which that's excellent news for us to receive at the board. Thank you, Matt. Nobody's hands up. So if we come to section 5, planning and strategic development. Bear with me when I find the relevant paper on my papers. So 5.1.0, which is our integrated medium plan Q2 report. Carl, this is over to you, I think.
Yeah, thanks, Chair. Excuse me. So the board know this is a regular report which is received throughout the year. You read the report, just a couple of things to highlight then in terms of at the end of this quarter, which was needed to deliver the 37 deliverables, and the key point under in the report says we are broadly on track. There are 2 which are slightly off track in the amber. And interesting, we discussed them this morning, actually, one of them, didn't we, in terms of trams, which is on page 24 of 40 in this report. And the other one is where we're slightly off track is the FBC for the new cancer centre. Again, we're fully aware of the reasons for that and where we're going. So last thing to say, fairly blunt tool as we've described earlier, but one of the processes we're currently doing in terms of preparation for next year's plan is a review where we think we'll end up at the end of March 31st in terms of these deliverables to set ourselves up for future planning for years to come. So I'm just going to pause there and happy to take any questions with Rachel, Peter and others.
Any queries for Carl on Pete? I don't know how serious a risk trams being fully established up and running by the time we move. There is a fair amount of time, but things before we're going to need the new service moving to new cancer centre. But it's taken us quite a while to get to where we are, and there's still a long way to go. So I would appreciate. We put this on a risk register, Lauren. I think we have, haven't we? So that we get a report. At the end of the day, I don't want to set hairs running, but at the end of the day, the SACT treatment's been available for our patients is our responsibility, and we can't say, well, we were expecting shared services to be presenting this. I'm not trying to be flippant about it, but it will be our responsibility. So we need to be sure, Rachel and I have already discussed this, that there is a plan B in place, which she's well aware of and on top of a little bit. But
I think it was quite timely, wasn't it, again? So we heard this morning. What we might do, Chair, so Neil gave an update, didn't he, where they are with the business case. So we could, following that, seek a more formal position in terms of deliverables, timescales,
Yes, please.
allow us then to hang our planning off. So I think that's something which would be really helpful. I can certainly action that. Alongside the work that Rachel's already doing with the service around contingency planning.
I think that would give us a lot more comfort because that we're not in a rush to try and put something in place should things not be finalised in sufficient time. But it does look as though a venue has now been established, which is IP5. Presumably they're going to move something out of IP5, so it looks as though a venue is established. So, so that's good news. There's a venue, but there's still quite a lot of work to do.
So IP5, the place they did that was the COVID screening centre that was then obviously would have been stood down.
There's a lot
between Newport and
there's a lot more in it than that.
Yeah, sure.
It started off as for COVID, which is why we purchased, and for Brexit is why we purchased it in the first place. And then it's been used for, what was the temporary medicines unit? What was that called? Temporary medicines unit, probably. Yeah.
it's that's where it is.
So that was based there. And then a lot of the storage that we needed for beds and PPE and so on from COVID was stored there. And then there was one of Julie Morgan's initiatives for new packs for mothers or was stored there. So presumably they're just changing use a bit, and so that trams can go in there.
There's already the pharmacy manufacturing there, isn't there?
Yeah. Yes, that's what I was. Yeah, that's what I was referring to. So, thank you, Matt. Thank you, Carl.
No, we still got
Vicky, I haven't called you in. Sorry.
That's okay. Thank you very much. It's just to ask Carl, because in QSP we outlined, didn't we, that we've got 18 actions within the IMTP that are requiring a remedial action plan. And I know we're going to come on to the accountability conditions letter, but are we confident that those are on track to deliver for the Q3 position for both ourselves as an organisation and Welsh Government?
Yeah, thanks, Vicky. So as I said, the QSP committee, and Peter and Rachel may want to comment separately, we've no other information which tells us otherwise. So as far as we are aware, those plans will deliver the requirements by the end of March. So nobody has raised their hand or elevated the risk to say major barrier, can't do. And see, Peter, thankfully, shaking his head in the right way, thing we're on track. And Rachel the same, I believe, not to put people on the spot, but I think we've done nothing different, Rach.
No. The only one I think I raised at QSP was around those which are part of regional programs of work, and there's external things happening which aren't in our gift.
Of course, because I said December, will be 9 months through the year, so we'll have a really clear view then, won't we, of the last 12 weeks. So we can come back with more certainty toward the end of December. But as we stand today, everything should be delivered as per plan.
Lovely, thank you, Carl. And is it possible just to ask a follow-up question, Chair?
Of course.
I think it was just to pick up and cross-reference back to the TAF discussion that we had before, Carl, because obviously in QSP we had the discussion that we would be cross-referencing these to make sure all of those are contained within the TAF. So is that work now ongoing so that that will be included in the January update?
Yes, it's reported in the TAF paper, Vicky, in terms of an update on that work. Sorry, it's buried in that table of development.
Yeah, I think I was just asking on the basis of remedial action plans and needing those assurances, and obviously being able to identify the gaps in controls or assurances. So it's just that alignment with where we're at and the progress that we're making. So that's hence the question. Thank you.
Okay. Can we go on to the
Sorry, delayed reaction. It may be worth, Vicky, because Carl and my teams are working on this, but the way you just articulated it may be worth having an offline conversation just to double check what we are doing meets what you think we're doing. Yeah, just the way you articulated them was potentially slightly more than we are doing. So perhaps we can just set that off offline sooner
Yeah,
rather than later.
more than happy to do that.
Yeah, that'd be brilliant. Thank you. Sorry.
Yeah.
Yeah,
that'd
thank
be
you.
really
Yeah.
helpful.
I just realised that my admin control shut down, so I've gone back into it. I need to find the paper again. I will be a second. No, I'm nearly there. I'm sure I'm nearly there. Gosh, there's a lot of paper, isn't there? Done that. There we are.
5-2.
So the second point that we were going to discuss under this item is the Welsh Government accountability's conditions. So you're going to lead on that?
Yeah, again, Chief, relatively straightforward paper in that standard practice. Again, thankfully our IMTP was approved. That was received 2nd of October there, alongside the conditions which are set out under para 1.2. So all we have therefore done is ascribe those to a sort of lead director, but also made the point of QSP quite clearly that all of those require the whole of the team in the organisation to deliver, albeit we've got a lead director, but it's for everybody to support. So again, fairly standard practice. And we'll then report against those accountability conditions. We are anyway, but make sure we get to the end of March and demonstrate we've delivered on those under para 1.2.
Thank you. Charles, please.
Thank you, Chair. I'm just going to ask on those items in 1.2, the condition, 3 of them appear to fall to the Chief Operating Officer and 1 to the Executive Director of Finance. And I just surmising really whether the Chief who's nominated the Chief Operating Officer to be the one responsible for those conditions, really, because doing 3 of them seems to be a bit of an imbalance of effort. And the second question, if I may, is just in relation to paragraph 3.1, where we say there's a quarterly progress report. And unless I've missed it, I wasn't sure when that. It says from November 2023. So I don't think we've had one for November 2023. Well, when are we going to get them, and when will the quarterly bits be?
Yeah. So I'll pick those up in order. So in terms of the first question, as I said at the start, it's a team effort, and I think if you look in the paragraphs there, under 1.2 bullet 1 as an example, Gareth, who's Chief Operating Officer supported by the executive and the divisional director. I know that feels like it's everybody's job, but I think it is everybody's job, and I think Matt, so Steve, the logic behind the coup being, and that one is the coup's got the biggest budget. So there's just a very obvious logic there. So the biggest opportunity, and
it's not the size of the budget. The coup is accountable for that budget. If I was accountable for it, I would have put my name on it. I can't be accountable for delivering something against a budget I'm not holding. So, but my team does everything possible to help the coup get the best out of the budget, and that's the only reason we exist. To support the coup, not the only, but one of the big reasons we exist is to support the coup. And whoever else has got a budget to get the best out of it. So we are very much there on the front line with them, but I can't be accountable. Whereas on the last one, I guess, reshaping the way our resources are deployed, the funding that comes in and how it's deployed in budgets is very much in my space about how do I help the organisation get a better budgetary control system that links income and spend in a better way and makes the connection. Obviously, again, with others supporting me to do that, but I should probably lead that with the chief executive.
Okay, and I suppose it does, at the risk of being mischievous, with the coup not being here, has she agreed that she's got these 3 positions allocated?
That's part of the issue, but I'm pretty much sure I've had these conversations before and she wouldn't disagree with them. But I haven't had that.
The deputies are here, governance-wise.
Right, okay. They logically sit with that budgetary reform. So in terms of savings program, 2 savings programs we got, the 2 divisions.
Yeah.
So it's a logic to it, Gareth.
Right.
Second question, and Gareth, good news. We're already reporting on those 4 actions. If you take the best savings plan, actions being taken to mitigate residual costs from COVID, those are things already in play which you receive reports regularly on anyway, so all we'll be doing, broadly speaking, putting that into a template which government got as a formal reporting process. So good news is you're already getting it, and it's easier for us then to pull together. But we will bring it as a government template so you can distinguish between normal reporting and what goes off to Welsh Government. If that's
I
helpful.
think that would be really helpful. Yeah, I think it would. Vicky, please.
I just wanted to ask a question in terms of the accountability conditions from last year. Has the board got confidence that we're tracking all of what were quite a lot of quality conditions that were set out in last year's letter? So I guess it's to Nick and Jazz in terms of, are we tracking those through so we continue to have confidence that we continue to meet those, as well as this year's more operational and finance focused?
I'd have to be reminded of what they were, if I'm honest, just at this point.
Did you mean in general, Vicky? For the
21-22?
Yeah, in
mean
21-22, there were specific issues that mainly came from the legislation in terms of duty of quality. But actually, what I was seeking was some assurance for the board that those measures which we had to track last year through the IMT quarterly reports continue to be tracked. And therefore we're keeping tabs on our performance of that. So it was just a generic question that covers the quality from last year, that we've got continued confidence that they continue to be monitored and where those are reported.
So Carl,
yeah. So the answer is yes, Vicky. So and you'll see we're in a bridge version, but in our slide pack for the JEC meeting, which we've just sat through, we take government through all of those conditions, so we can send you the full slide pack. That was, so I'll give you as an example, if I can just quickly get to them. There were things which are again around delivery of, for example, the radiotherapy satellite sent to the AOS service. There's quite a list of quality stroke service issues. So I'm looking for them now. So they are being tracked, and again, there are normal report. Yeah, we've got them now. Implementation of the clinical service at AB and our Bevan, implementation of the RISP system, the SACT improvement program, outreach, regional AOS, and all those are in our accountability conditions for this year. So we track those through our current IMTP process, and as I say, we fed back to Welsh Government at our JEC meeting, which I think was a couple of weeks ago. So they are being tracked. I think it's a useful point though. Have we formally brought them here? Probably not. So I don't know. We can certainly do that if that would, I guess, close the governance cycle, if you see what I mean. If that would help.
That'd be really helpful. Thank you, Carl.
Comment really on that. It'd be interesting to reflect whether these are cumulative conditions.
Wow.
Or when the year went, doesn't mean the issues flagged up, Vicky, aren't important, because I think we might want to be making sure we monitor against those. But there's no indication that they are cumulative conditions that we have, because some of those things are not one-year issues, are they? So I think we might want to, whether government see them in that space, I'm not sure, but I think we ought to keep an eye on those anyway, because they're important.
Yeah, that's helpful, Steve, because that's why I was asking the question. Thank you.
So would it be helpful to set that out in a report we can just see it easily?
Well, I think
I know it's embedded.
I think when we get a report, make it cumulative, because
Yeah.
choose to.
Yeah. Can we do that?
Yeah,
that's fine. Thank you. I haven't got any other hands up. I'm looking around. So we note this report and the Welsh Government accountabilities conditions, and we've just agreed an approach for reporting against the Welsh Government conditions, which we're already doing, but we'll see in a bit more detail January meeting, I should think. Carl, everybody's content with that. Thank you. So if I can take us to 5.30, which is the bed establishment computer system, very important issue for us. This again is led by Carl as Director of Strategic Development, Transformation and Digital, and will be supported by yourself, Peter. Is Carl joining us?
He's going to join for the private session.
All right, okay, yeah, okay, fair enough. So can I hand over to you, Carl, to...
Yeah, we're looking at each other. Yeah, yes, of course, yeah. So just by context,
how best you want to do
the
it.
expert. So clearly the paper is self-explanatory in that we have the VEC system. It requires procurement. And then if you just draw the board's attention to perhaps the key paragraph in the report, which is around 1.9. As we know, there's quite a challenging operating environment in terms of replacing said system. And then Peter, Alan, and our team have been doing a whole load of work around what are the options we have available to us. They're described later on in the paper. And in essence, Chair, what we're now looking to do is work through those options to identify the best route forward, not just in terms of the procurement of the overall system, but in the context of quite an exciting and ambitious programme of work to help transform the system, but also to keep the wheels on the bus, so to speak, in terms of blood and blood products. So that's where we've got to. And as I say, there's I'll just pass to Peter, but there's a further conversation in part B, because clearly an aspect of this is it's got some commercial matters related to that. So Peter.
Yeah, the main thing, I just to pull on a level of detail below where Carl has given us the context. The blood establishment computer system is an absolute fundamental for blood safety. It's our means of tracking blood from the donor to the patient. There are a whole host of very, very hard regulatory requirements that have to be fulfilled, and we have to provide ongoing evidence that we're maintaining and validating the system in a state that gives assurances of the safety. That sits alongside a similar set of requirements in the histocompatibility and immunogenetics systems, where we've also got an ambitious program which has recently been approved to upgrade systems there. So what we're now facing into is what are our options for sequencing and phasing that to make sure that we can deliver both of those safely and in a regulatory compliant manner, whilst at the same time meeting the public procurement rules, etc. But it's certainly challenging. There are an awful lot of commercials that need to be considered. I think they'll be picked up in the private sector
later today.
Yeah, private section.
Okay, so for this section of the report then, thank you for the update. Thank you for drawing to our attention some of the challenges in relation to sequencing and phasing. And we'll continue this discussion because some of the commercial sensitivities, it's important that we continue this discussion in the private part of the agenda. It's happy for me to move on that basis. Thank you. So now we come to section 6 of the report, which is the consent items. And I want to, I would always ask at this stage if people want to pull anything out of consent and discuss it. So in advance of handing over to the board to raise issues, I want to inform you colleagues that under 6.1.4, number ABC, the Shared Services Registration Authority policy, we're pulling that for today because we have noticed that there's still considerable work that needs to be undertaken and that it isn't really in a position to come to us for approval today. So it will come back. It might come out of committee, but it will have to come back. So I'm just informing you that I intend to pull that.
Thank you, Chair. Just, I think it's 614C, 614D and 614E because they're all related, in fact, with that registration.
Let me just find all of those and Garth, because I will need my 6.14 only goes up to C. 6.1B, 6.1D, which is C Appendix 3.
So it's just C. I think all of them are. I think they're all related.
They're appendix.
the appendices to it.
Okay, it's just the way
Go into the.
Okay.
Yeah, sorry, it's a
We need
labelling
to
on
do
admin
6.1D.
control. It is one item.
Okay.
Yeah.
Apologies.
No, no. I see what you mean, yeah.
Yeah. Okay, so, so it might have to come out in, out of committee, it depends, but otherwise it'll come, but in any event, it will come back to board. So, colleagues, does anybody want to pull anything else out of consent for discussion? I was just looking to make sure that there's nothing on my own notes. No.
That's just.
Oh, Matt.
I'm not taking it out of consent, but the 100k paper, should it say in the cover paper?
Can you tell me which item you're looking at?
So the cover paper for the 100k expenditure exceeding.
6.11, is that?
Yeah, page 2 of 5. It says the executive management board reviewed and approved. Is that what we're meant to say? Sorry, I'm just checking. I should know this. I thought it was endorsed.
I can't hear you, Matt.
It should
Yeah,
say,
it should-
endorsed for board approval, not approved.
I just couldn't hear you. I'm so sorry. Not discreet me.
It's volume adjustments. Extreme.
They really blew me off my chair.
Oh, when going.
So here it should say endorsed.
Thank you,
that's
Matt.
correct.
Yeah, important point. Thank you. So with that, given that change, he nearly blew me out of my chair. Is your point in relation to that, or do you want to pull something else out? Right, let me finish with this one then. So under 6.11, which Matt just asked to be put out of consent in order to change approved to endorse. Are we content then to authorise the chief exec to approve the awards of contracts just summarised in that paper and the supporting appendices, and then the chief exec will be approved to approve the requisitions for expenditure under the particular agreement?
Apologies, Chair. It is in the context of that same item. Apologies. Sharp intake of breath. It's on page 5 of 8.
In 6.1.1.
It is in, yes, it's in 6.11B appendix 2. So it's one of the items of expenditure under 611.
Okay, thank you.
So page 5 of 8. Paragraph 6.2 outlines the procurement strategy and says that it is a direct award via an NHS framework, which is fine and implies it's a new agreement. Whereas in 6.3, we say in the final sentence, the renewal of this contract poses no cost pressures to the trust. So I just think we need to be clear as to whether it is a new contract award or whether it is a renewal. To me suggests an extension, I think.
Can I, apologies, can you just confirm which item we're looking at?
This is right.
Right, let me ask Gareth the question. Which item are we looking at, please? 6.1.
It's 6.1.1B.
Right, appendix
2.
Appendix 2, that's where I am.
The All Wales human, all renewal of all Wales blood derived products contract.
Yeah, you were on the right page.
I was on the right page.
Yeah, you were in the
Hang on, beg your pardon. I think that the numbering is a bit awry.
It's under contract renewal, isn't it?
6.1.1B appendix 2 is find tender.
Okay, it is then. It's a provision of on-code type testing. Sorry. Which is page, if I give you the aggregate page number 296 of 786.
Can you remind us the question?
Yeah, the question is 6.2 refers
Yeah.
to a
Yeah.
direct award under a framework, which is fine in principle, except that in 6.3, it says it's a renewal of this contract. I don't know whether that's an extension of an existing contract or whether it is it's just.
It's a new contract, is my understanding.
The indication
Contract ends today. I think. But this is the only supplier, and in theory, long contract, we were hoping Cardiff and Vale Health Board they started to supply this, but they're struggling to get.
They're not.
It's a new contract, as I understand.
And the
with the same supplier.
indication is slightly increased as well, so I think we agree with that clinically.
It's a new contract. Okay.
Yes.
Chair, apologies for taking us down a rabbit hole. You can forget the challenge.
I'm only just finding the position we were in the paper, actually.
You don't need to do that.
It's fine now.
Yeah. We've moved on.
We moved on.
It's a new contract.
Thank you.
Thank you. So, no other hands up. So I'm asking again then, at the 6.11 and the various appendices set out there, I'm looking for approval to authorise the chief exec to approve the award of contracts summarised in that suite of papers, which will then authorise the chief exec to approve requisitions for expenditure under the particular agreement. Are we all content to do that? Thank you. 6.1.2 is Chair's urgent action report, which again we're asked to consider and endorse. Very busy Chair's urgent action times at the moment, which is a reflection of just how much activity we're involved in. But we're required to consider and endorse the Chair's urgent actions taken between 20th of September and the 22nd of the 11th. Are we content to endorse, please? No hands up, so I'm taking that as yes, thank you. Then we come to 6.13, which is revisions to the model standing orders, reservations and delegation of powers for NHS trusts and model standing financial instructions. This, any queries can be, Matt will would take, but I think Matt is hoping that Lauren would take it. But what we're going to be asked to do is to approve the adoption of the revised model standing orders, reservations and delegation of powers for NHS trusts and model standing financial instructions. Lauren, did you want to, this is in consent, so unless nobody's asked to take this out of consent, so I'm going to move that we approve. Thank you. 6.1.4 is the trust policies for approval. And we've removed one of these, as I said at the outset. So we're just looking at the trust claims policy, handling concerns policy. Those are the two that we are now looking to approve. Okay, everybody is content there. And then 6.15, this was a paper that Peter referred to earlier, which is the NHS Wales Red Cell Shortage Plan. And we're going to be asked to approve this plan, which is set out in huge detail and minute detail. And the only query I would have is, in the middle of an emergency, this is an awful lot to hold together, Peter, in terms of what's to be done and where it's to be done and how it's to be done.
So it does, but I think the point to remember is that the policy covers an end-to-end process that spans a lot of different parts of the organisation, and it does get broken down into specific parts for specific people, groups of people. So,
so for any one individual, it's manageable. Yeah. Okay.
Yes. And most of the content of it came from a tabletop exercise that we conducted across NHS Wales exercising a red cell shortage. I think Alan's online now, he'll remind me, I think it was 2022 we did that. And then since then we've been through a number of cycles of consultation with the stakeholders. So I agree with you, it is very, very comprehensive.
Very comprehensive, very detailed.
But you're absolutely right. I'm also in the same place that, you know, there are certain areas where actually an SOP is not required. You know, and for instance, using a defibrillator would not be a situation for an SOP because it's an emergency. But this one, it sets out the framework that we will then jump down into basically a series of action cards, so that in the moment you pull an action card.
Oh, right. Yeah.
And my team would be more than happy to take you through that if you're interested.
Might be. Is this the paper where you were going to redefine blue alert?
Yes, that's one of the big changes. Is that in Wales we refer to a challenging situation that doesn't yet require rationing as a blue alert, whereas the rest of the UK refers to it as a pre-amber alert.
Pre-amber.
Yes, so we're bringing that in line with the rest of the UK. There are some other changes there because we found ourselves in a couple of situations over the course of the last couple of years where we've been thinking, well, perhaps we should be asking for support from another blood service because they're not in an alert status, and then when we've gone to their stock level, it's actually probably slightly worse than ours because they've got slightly different triggers. So there's alignment of the trigger levels and alignment of the terminology, so that all of the UK services are talking the same language with their clinicians and with each other.
So we will be saying blue alert, we'll be saying pre-amber, okay, going forward. Okay, that makes sense.
So Gareth can unlearn this morning, class.
Thank you.
So we approve that plan. Thank you, Peter. Then we've got the shared services partnership renewal of lease. We're asked to approve the renewal of the lease between Shared Services and Treforest Trustee Jersey Limited. I had a few queries with dates, but they've been explained to me now, so I'm content. So I move that we approve the lease. And then for noting, we've got trust-wide approved policies update, the Public Strategic Development Committee highlight report, Public Charitable Funds Committee highlight report for noting, the Public Transforming Cancer Services Programme Scrutiny Subcommittee highlight report for noting, the Remuneration Committee highlight report for noting, Local Partnership Forum highlight report for noting, and Welsh Health Specialised Services Committee briefing for noting. We've got the EASC, the Emergency Ambulance Services Joint Committee briefing for noting. Then we've got the Shed Services Partnership Committee Assurance report to note. Trust Seal Approval report for the affixing of the seal. That concludes the consent items. Oh, sorry, Gareth, I didn't see your hand up.
That's okay. May I ask one question, please, regarding item 6.2.1, which is the trust-wide approved policies update. And I think the implication from this is that some of the policies haven't been reviewed within,
as we discussed earlier.
That's right, absolutely, in a timely fashion. I wasn't sure whether to ask the question earlier or now, but are there any legal consequences or implications for us if we haven't reviewed these policies within the
required time?
Yeah.
No, so the policy is still extant.
The existing policy is still extant and there's nothing.
Yes.
Extant.
Yeah.
And there's a plan in place to get the ones that aren't yet re-approved.
Yeah, sorry, you need to be looking at me. Yeah.
Why am I looking at Nicole? I don't know. But
Yeah.
dresses and things.
Nicola's not making eye contact.
No. And now Nicola's under the table.
Yes, so there was some challenge from Vicky before QSP, which is reflected in this version of the paper, and then the summary from QSP is there as well. So, so that will be picked up in the next report.
Consent, Gareth. Thank you. No hands up, no virtual hands up. So I'm now taking us to any other business. I haven't been informed that that anybody requires anything under any other business. And so I want to say the date and time of the next meeting is the 30th of January 2024. And hope everybody has a happy Christmas between now and then and has some rest and recreation. And now the Trust Board is asked to adopt the following resolution: that representatives of the press and other members of the public be excluded from the remainder of this meeting having regard to the confidential nature of the business to be transacted, publicity on which would be prejudicial to the public interest in accordance with section 1, paragraph 2, Public Bodies Admissions to Meetings Act 1960, paragraph 67. That concludes part A, colleagues. It's 14:31. We can have a 15-minute
Yeah, start
break.
part B at
I will
2:45.
start part B at 2:45.